And the theme for this year is Unite for Change, Unite for Equity. You'll be surprised by certain statistics. This rare disease affects 3.5 to 5.9% of the population. 72% of the rare diseases are genetic, and 70% have no treatment. So it's the time that we share their colors. And what is equity for people with rare disease? Equity is eliminating barriers to care. Equity is demanding social inclusion. Equity is fighting against discrimination. We've gone a long way from 2008, when the first Rare Disease Day was celebrated, to 2021, where we moved towards UN resolution. So friends, as Society of Fetal Medicine, we are here to be with them, with all of them with rare disease. Together, we can do more.
There's no audio in the video.
Yeah.
The Society of Fetal Medicine is here to share your colors. I now request Dr. Ashok Khurana to kindly take this forum forward.
Thank you. Thank you very much, Rima. That was nice. Unfortunately, we could not get the audio, and perhaps we'll play the audio at the end of the program today, because we couldn't hear the audio on your video. And perhaps we'll run it when you have an audio connection as well. Before we go ahead, can we get the messages in from our trade partners today, and then we will go ahead with the rest of the program. And of course, a very good evening to everyone.
I will play the videos.
Yes. Atul, can we share the videos, please? Wonderful. So a very good evening to all of you again, and welcome to this very special program on the Rare Disease Day. You know, it's always held on the last day of February every year. And since we have a leap year, we're holding it today on the 29th. And we have a few interesting things lined up this evening. I will introduce the topic, and then we have a very nice presentation by Dr. Sudhendra Rao from the Organization of Rare Diseases India, followed by some judged abstracts. So we'd invited abstracts a few weeks ago, and those of you sent it were then sent for judging, and they will be presented after the two formal talks. So let me go right ahead and start my presentation, which is more of an introduction than anything else. And I will introduce this topic of rare diseases. And to give you a rough idea of the things that we truly talk about, basically, there are some different definitions, which we will consider in a little while. But there's about 300 million people worldwide currently who have this so-called rare disease, about 30 million of them in the US and 30 in the European Union. But what is important for you and me is that there's 7 to 8 crores of these people in India which are affected by rare diseases, which really means that about 25% of the global burden is sitting with us. I know it is inappropriate to use the word global burden or burden in that case, but the fact is that we do have these. There's about 7,000 of these diseases, and Basically, about 70% of these start in childhood, and most of them, 95%, have no approved treatment. The other tragedy that we have to cope with is that it takes, apart from the period that you and me handle, which is the antenatal phase, typically a patient would take between 4 to 20 years to have a diagnosis, and it's missed a lot of the times. Within India, we have a much higher incidence in Uttar Pradesh, Maharashtra, and Bihar, but this could be a registry bias because not everybody reports these diseases all the time. But the important thing for you and me is to get sensitized to this because we need to start thinking rare diseases for the simple reason that 1.4% of newborn children are affected by one of these diseases. And that's where you and me come in, the antenatal period, where we need to go into clinical features of the family, ask them specifically whether there are any diseases that run in the family or any of the relatives have something unusual going on, not directly sometimes, but indirectly, but definitely by the end of the clinical interview, something that you and me need to be sure about, so that we can then decide, with or without the help of geneticists and other specialists, that we need to investigate this further and reduce what would then be the so-called burden. But more importantly, give our patients the choices on whether they would like to have such a baby. And for those of them who do opt to have babies with these problems, they will then be prepared for problems when the baby arrives, which means that the problem would then be much more manageable in that situation. Moving on, therefore, I will move on to this definition business. And most countries have their own definitions. And this is always in the context of their own population, their healthcare system and resources. And whereas the WHO defines rare diseases as one in which the prevalence is about 1 per 1,000 or rarer. But we have a more liberal definition from the Organization of Rare Diseases India, which suggests a disease to be defined as rare if it affects 1 in 5,000 people or less. When we talk of this definition, we realize that, of course, we should include the total number of people having the disease and then the prevalence, of course, more importantly, the availability of treatment, which is either not there at all or not available, no access to it, or too expensive. And this is something that we will discuss during the course of the evening today. What I use when I work with these conditions, and in a lot of cases when I'm working during the day, is to work with Orphanet. This is something that was actually published a few years ago, 12 years ago. The Orphanet approach to serve a wide range of end user, which came out in the Journal of Human Mutation. And it contains review articles, a lot of stuff on genetics, abstracts, all put together in sort of an encyclopedia base, combined with clinical data, combined with classification and science, which you can use. And then, of course, that group, which is called the orphan designations, which is a part of the rare diseases. And then, of course, it has databases such as the HGNC, OMIM, and so on. It also has access to ICD codes, ICD-10 codes, OMIM numbers, and so on, PubMed queries, and then a directory of services that patients can use. So this is something I want you to be aware of, and the reference is written right there. And you will find it useful when you're trying to either locate a disease and otherwise when you're trying to find more information on this disease. A little more on how this Orphanet works. Of course, there are other sources also that you can use, but I just find this particularly useful, is that you also have this great business of classifications. And the granularity of these classifications is quite different, which means that it is possible to map to any other resource in a one-to-one manner. So entries in a genetic-based database like OMIM will map to deeper levels in the hierarchy. And the clinical-based ones like the ICD-10 will map to higher levels in the hierarchy. So if I were to get stuck with, for instance, asymmetric slowing of fetal growth, as this graph shows here, and I have excluded my intrauterine infections, the presence of a structural malformation, and of course, placental insufficiency and the immune disorders, then I would then go on to genetic disorders, one of which would be the Silver Russell. But I will make sure that when I do my genetic testing, which means my amniocentesis to exclude this condition, I'll make sure that my database and my worker who's going to work on the genetic aspect of the amniotic fluid will look for 11p15 microduplications, will look for 7p11.2p13 microduplications. It could be an imprinting defect of 11p15, or it could be a maternal uniparental disomy of chromosome 11, or a maternal uniparental disomy of chromosome 7. So this is information that then comes at your fingertips without having to struggle for it, and therefore I find it extremely useful. As another example, do remember that you must be sensitive to patients who have genetic issues, either from something obvious like this, which is morbid obesity and extra toes, but also some patients who've never reached a diagnosis and have been unwell for a while. Those patients who've been visiting their family physicians too frequently, many specialists, etc., and still don't have a diagnosis. And then again, take that over to Orphanet, where the classification is based depending on either the ciliopathy, which means the actual condition, or a syndromic retinitis pigmentosa, as is listed here, or under the title of obesity and genetic syndromes. And then when you have this list, you can make sure that yes, it can be done. Of course, the job is made much more easy by the presence of our geneticists today. But this goes to show that even if you don't have them readily available, you at least have a working classification. So at the point of first care, when the patient first comes to you and you're sitting in your practice in a small town or without access to a specialist, even in a big town, you can get things going and saying that, look, this is how we need to plan out this pregnancy, and this is a resource that you would then use. The Orphanet also classifies things not just in terms of a pathophysiology, etiology, and stuff, but also in terms of diagnostic tests. So, for instance, for a congenital adrenal hyperplasia, it first informs you that there's a classic form and an atypical form. Then it tells you about the fact that there are enzymes that are not going right and that there are genes for these, and you have an abnormal cholesterol synthesis. Then, of course, a method of how to diagnose that, how to prognosticate that, the possible management and when to do it. And then you can go on to figure out other information on how to handle this. So for instance, if I were to be faced with this situation where I was suspecting a congenital adrenal hyperplasia due to a 21 hydroxylase deficiency, I draw baseline maternal serum estriol at 5 weeks, start DEX at 20-25 micrograms per kg per day orally, and then at 8 weeks begin a monthly bi-monthly fasting blood sugar, and then follow it up with either a CVS or an amnio. And depending on that, and then of course making sure whether you find out whether the fetus is female, and here it's very much a permitted part under the PCP and DT, you'll then go on to continue the medication depending on this. And then you might decrease the dexamethasone dose depending on the maternal low estriol level. Of course, it's not that everything is there in Orphanet, and you will need to go to references that can guide you through this. But the good news is that most of the management references are also included here and are worth looking at. We are lucky in India to actually have a national policy on rare diseases, which came out several years ago, but was last updated in 2021, where we're seeing an increased focus on these conditions and the fact that almost all the people who have a rare disease in India are facing limited or non-existent access to treatment. And this national policy is going to try and meet those needs. And it's a very brief but exhaustive document. And the idea is to lower the high cost of treatment for rare diseases. The plan within the government echelons is to boost indigenous research, to create a national hospital-based registry, to create Nidan Kendras for early screening and prevention and appropriate referral, and to strengthen secondary and tertiary health facilities at centers of excellence. These centers of excellence are listed here. But what is important for you and me on a daily basis is what I've highlighted in yellow here, which is the primary prevention by identifying high-risk pregnancies. And this means that you do need to be sensitive to the fact that, yes, there are conditions that need to be looked for that might not have been identified in patients who come to you during pregnancy. And that is the way we need to look at them. Of course, there are those aspects of secondary prevention that are within this plan for rare diseases by taking steps to prevent the onset of complications by starting treatments and by actual rehab care, and tertiary prevention through provision of better care and rehab again for these patients. And do remember that this is an expanding list for centers of excellence, and you could consider if you're at one of the other centers to be included in this list by communicating with appropriate sections of the Ministry of Health and Family Welfare. When we look at treatments, typically India categorizes rare diseases into three groups. The first is disorders which are amenable to a one-time treatment, which can be treated with either a stem cell transplantation or an organ transplantation. The second group are those that require long-term or lifelong treatment with a relatively low cost. And the third one is the tough one, because these are diseases for which definitive treatment is available, but challenges are there to make this available for patients because of either high cost or the fact that it's to be given for their whole life. There is, of course, the fact that you can get rupees 20 lakhs from government sources, and I know Dr. Sudhendra Rao will highlight this for us. We've also had money raising by NGOs and foundations. We've had a lot of cooperation from pharmaceutical companies who manufacture these and make these available. But we also have the option of crowdfunding, which is where we use social media to say that, look, so-and-so has this disease. They don't have the money for this disease. This is the amount of money required. And could everybody who sees this on social media put in their bit into this particular account by transferring that amount of money? So it is not that there are no answers. We are able to find answers. And this is something that you and me need to look for. And this is what the future is going to be all about. And this is what our evening is going to be all about. So thank you so much for your attention. And we will take questions a little later. But for now, let me introduce the true technical man for today. And our speaker now is going to be Dr. Sudhendra Rao, who is a physician scientist. He has an MBBS background from Mysore and then went on to do a PhD in molecular neurosciences from the National Brain Research Center in Manesar near Delhi. And then following this, he was with NIMHANS for a while, and then at the University of Miami in Florida, where he focused on cell and gene therapy for spinal cord injuries. And on coming back to India from there, he worked initially at the NCBS Bangalore, but then soon went on to be a part of the pharmaceutical industry, where he was developing a lot of this work, GMP manufacturing, the GLP studies, and so on. Currently, he is a scientific advisor at the Organization of Rare Diseases India, and also has been contributing to the advancement of rare disease research in India with the help of the healthcare company he works with in Bengaluru. So over to you, Dr. Sudhendra, for sharing your screen and for speaking to us over the next 15-20 minutes on how we can approach this particular problem. Thank you.
Thank you so much. Thank you so much, Dr. Kurana. Am I audible?
Yes.
Thank you. I'm sharing my screen. Please let me know once this when you're able to see the screen.
Yes.
Should be visible now.
Full
Okay.
screen, please. Yes.
Yes.
Wonderful. And we hear you clearly with your screen and we see your pointer.
Thank you so much, sir. Thank you very much, Dr. Kurana, for the invitation and the Society for Fetal Medicine. And this seems to be a very appropriate day to discuss about rare diseases. In fact, one of the rarest of the rare days, 29th of February. And I am representing Organization for Rare Diseases India, which is an umbrella organization made from the contributions of the parents of the patients who are suffering from rare diseases. So that is the uniqueness of this NGO. This is my sister suffer from spinal muscular atrophy, and the co-founder's daughter actually had Pompe disease. So that is the Organization for Rare Diseases India, and the members are all patient advocacy groups who have kids suffering from either Rett syndrome or lysosomal storage disorder, different tuberous sclerosis, and you name the disorder, we have those kind of patient advocacy groups working with us, and they are equal partners in this particular work that we are doing. And today I'm going to talk majorly about India. My focus has always been about India. I want to give you just a glimpse of from the advocacy perspective, what we have done in the context of the rare disease of the world, and also what should be the way forward. You guys are all technical people, you know far better. You are able to see the diseases well ahead in advance. I'm not going to tell you what is coming. Of course, I can probably talk a little bit about the tech part of it, but you would know far more than that. And as one of the speakers also mentioned, the rare diseases, the exact definition of rare disease is not there. But how many rare diseases are there? So previously we have thought that there is a general accepted definition that there are 7,000 rare diseases. But if you start digging for it, you will never be able to find 7,000 rare diseases. And if you go to Orphanet, as Dr. Quran was mentioning, and Orphanet has around 4,500 rare diseases, which are unique. And when I was speaking with the founder of Orphanet, when I met her in Paris, so we were discussing about this particular conundrum of how many rare diseases are there, and as per her, it is very important that these particular diseases are separated by phenotype and genotype in a very distinct manner. That is the reason why you have around 4,500 rare diseases there. But if you start digging for a very minute phenotype, so changes in the genotype, minor changes in the genotype leading to subtle and quantifiable changes that can be captured in the phenotype, like if you do a deep phenotyping using HPO terms, then it is possible that there are around 10,363 rare diseases. That is the paper that came from Handel et al. In 2019. So that actually increases the number of rare diseases which are already, we were thinking that 7,000, the number is probably 10,000 or more. That is what the thing. And Dr. IC Verma's seminal work and multiple other work at the ICMR has already documented more than 450 rare diseases in India. And we do not have a definition of rare diseases, as Dr. Khurana was mentioning, but orphan drug has been defined in the clinical trial and drugs law 2019, where orphan drug, if you try to see, orphan drug is any disease that targets any drug that targets a disease which is for which not more than 5 lakh patients are there. So if you cross calculate and back calculate, that would come to somewhere around 1,250. So we have a definition for orphan drug. That means a drug which is targeting not more than 5 lakh subjects. But we do not exactly have a definition of rare disease in India because of the logistical issue of doing a large scale epidemiological study. And but one of the important points that I want to highlight, the issue with rare disease in India is the consanguinity. The range is 5 to 15%, and there is regional variation. There are variation due to religion, economic, urban, and rural, and education dependent options are there. These are some of the things which are contributing to the rare diseases, and this is where gynecologists come in, OBG people come in, and so that awareness is needed to ensure that at least this is a preventable part of rare disease, or any type of genetic disorder. We can actually prevent it well ahead. So this is something, as a society, we definitely should work on to decrease the number of consanguineous marriages in the society. That would ultimately decrease the burden. This is very easy to approach, but difficult to implement. And then second thing is, we need to have an exact reality of what is happening with Indian population, the genetic per se. Day before yesterday, Government of India concluded 10,000 genome project, which was already completed long time back, but officially yesterday they put the curtain down. The data will be available in Faridabad, the Department of Biotechnology Center, which is there in Faridabad. The data will be available there. Hopefully, everybody will get appropriate access to it to analyze the data. But Dr. Tangarajan from CDFD, who was in this particular project, when I was speaking to him when he was in Bangalore last month, at that time he did talk about changing genetic landscape of India, and we are we are having a lot of recessive disease, recessive gene burden. So what this means is we are going to see more and more rare diseases which are carried by the recessive allele, and we would need to be prepared for it from multiple standpoints, both at premarital counseling to prenatal counseling, and postnatal screening and things like that. So we need to keep this in mind, and government has already taken note of it, and there is already an emergent regulatory landscape change and policy, as Dr. Quran also already highlighted. There are a lot of changes that are happening. We had Drugs and Cosmetics Act 1940 that has now changed, that in 2023, in 2024 we will have a much more mature drug policy for manufacturing purposes. We also have a medical devices policy. A lot of rare disease patients use medical devices like CPAP, BiPAP, or any type of suction. A lot of medical devices are used by rare disease subjects. New drug and clinical trial rules came in 2019, and there is going to be a couple of amendments to that as well. And orphan drug was also included in the recent amendment for the new drug and clinical trial rules. In addition to it, government has strengthened the research infrastructure and the regulatory and the policy and the guidelines aspect that are needed for it by providing national ethical guidelines for biomedical research involving human participants, national guidelines for stem cell research in 2017, and national guidelines for gene therapy and development of gene therapy products for clinical trials in 2019. And to the cherry on the top, we now have a national policy for rare diseases in 2021. There are significant amendments to that as well. And one of the major amendments is the removal of Group 1, Group 2, Group 3 for distribution of money. So 50 lakh, initially it was 25 lakh, that has been increased to 50 lakhs. And these 50 lakhs is available to the centers of excellence. We have 12 of them now, more of them coming in the future months. And these centers of excellence have this judgment on the patients to whom this 50 lakh can be provided. And as long as the disease figures in the national policy for rare diseases 2021 and in the amendments, these 50 lakhs will be made available to each and every one of them regardless of the group they belong to. So this is the new amendment that the government has done, which is very welcome. But we have asked government to increase this 50 lakh to 1 crore rupees, and also look at rare disease management, not just from the treatment perspective but also from the management perspective. And regulatory aspects, if we continue to look at it, they have defined the orphan drug. They have given a lot of waiver in terms of complete waiver for clinical trial development of orphan drugs, faster approval. So if there are any drugs that are being developed, the India is kind of getting ready with its regulatory landscape, including clinical trial waiver. And there are, of course, there are certain requirements for clinical trial waiver to be obtained, like major SAE should not be there. The drug should be already approved or marketed outside India, approved by CLAs, like very authorities, the license authorities like US FDA, UK MHRC, Europe, and Japan FDAs. And then there should not be the expectation of minimum ethnopharmacogenetics or ethnopharmacokinetic minimal interferences should be expected. And then they should give assurance for to conduct a phase 4 in writing. And this can also be waived depending on the unmet need and the life threatening quality of the disease. So government has gone really, I should say, all the way in ensuring that there is a growing usefulness for the clinical trial conductants in India. However, we see that a lot, if you see outside India, there has been a huge amount of increase in the organizations and in the pharma companies which are putting their money in rare disease drug development or orphan drug development, because FDA offers a lot of incentives to create drugs. And gene therapy products are there. In fact, day before yesterday, the main person from the FDA, Dr. Marks, was talking about expedited approval for gene therapy will become a norm. That means if you have a product and you can show that it is actually showing improvement in animal models, and maybe phase 1, they would probably give market authorization, taking the risk. So the government and the FDA and the regulatory authorities outside India are really ensuring that newer and newer products for the rare diseases are coming up. But everybody knows the cost of these particular rare disease drugs are going to be huge, and most of the Indians are not going to be able to afford that. That is because of the various reasons. One, these market authorizations, most of these drug manufacturing firms which are developing orphan drugs are not coming to India to market rare disease drugs. Very few of them are coming. Zolgensma has not yet come, but they are doing compassionate access program in India. Resdiplam from Roche has come for spinal muscular atrophy. They are marketing, and a couple of more from the AstraZeneca. They are targeting neurofibromatosis. That is coming. But on a long term basis, we always believe that we need to have an appropriate research ecosystem in India. Please remember that more than 80% of Indians do not have a proper insurance. Actually, health insurance is not there. There's a lot of out of pocket coverage for the healthcare accessibility and healthcare facilities. To access that, and people are spending money from their own pocket, so it is not possible to have an appropriate method by which right now the products that are getting manufactured outside India, they can come in and people will start affording. So that's not going to happen. That will take a lot of time. Parallelly, we should also also have this particular reality that Indian pharma industry has always been service oriented. We do manufacture a lot of active pharmaceutical ingredients next to China, but most of our formulations are not done in India. We send these APIs outside India, and then formulate it gets formulated and then comes back to India, and the cost will increase because of the formulation. So that is the reality that we have. And secondly, we do not have an ingrown, homegrown innovation kind of industry in the pharma for various reasons. Majorly, it is the business reason. That's the thing. And also, we do not have this, technology transfer where a lot of products are already being developed by the Indian startups, so that the pharma company can take it and develop it into a product. So to address all this, organization for Rare Diseases India, we are directly tying up with different partners who are working in the research area, and we have created an ecosystem wherein all the participants who are interested in rare diseases, they can come and develop and talk and exchange the ideas, so that over time we will be able to create a thriving ecosystem which can arrange itself to face the challenges of rare disease drug development in India itself. Now, I'm proud to say that we have now finished the second Rare Genetic Research Summit. In fact, ICMR has also joined. You can see ICMR, Dr. Nabendu standing there. Dr. Tangarajan is there from CDFD Hyderabad. Dr. Rakesh Mishra from CDFD Hyderabad previously, and our Prasanna Shirol, who is our co-founder. In fact, we also have a representative from Novartis standing there. So a lot of people from very different companies and very different background all came together for second Rare Genetic Disease Research Summit. We brainstormed. We talked about cross pollination of the ideas and to address the challenges of rare disease research community. And on the reality side, we are directly working with centers of excellence in Bangalore. We are working with CDFD Hyderabad centers of excellence of rare disease. We are working with AIMS Center of Excellence for Rare Diseases to ensure that the patient journey is also addressed, and these patients were given enzyme replacement therapy. And we have also been working with other hospitals like Baptist Hospital, where we are giving gene therapy, risdiplam, any other ASOs that are coming. But we are also ensuring that the rare disease care is not just for the treatment per se. It is actually, most of the times, if you actually look back, what is happening to the rare disease patients, so like gene therapy or anything, most of the times they die because of the complication, not because of the treatment had an SAE or something like that. And these complications would be easily preventable if there is a multi-center approach is avoided. But all the different kinds of treatments that are needed to ensure that the health of the patient is kept well, like yeah, cardiologist is also looking after, the skeletal muscle specialist is also looking after, gastroenterologist is also looking after, so that appropriate gastric interventions are done for the spinal muscular atrophy cases. Those kind of multiple specialty together taking care of rare disease, that sort of thing is needed, not just the treatment aspects. And that is the reason that sort of of thing we are asking for people to understand that rare genetic disease is not just about rare disease itself, but it is about ensuring that the community comes together, and community of doctors coming together for the patient on a holistic care. But at the same time, we have to also ensure that the awareness is created through multiple marathons or webinars and things like that. But if you imagine, I mean, if I say that a fetal medicine doctor, they would have already seen this most of the congenital abnormalities you would see well ahead in hand. And things are also changing. People are giving enzyme replacement therapy in utero. And there was also a case where spina bifida was treated in utero by giving appropriate medication. So the people are always already moving forward in the kind of next generation treatment that is coming up. And if we can try to do an intervention early on, so that we catch these rare disease patients early on and provide the treatment, probably we don't have to have these many cases coming out with much more severity. And another issue that we are always seeing is that the rare disease definition itself, like what is rare disease in USA? Like malaria is a rare disease in USA, it's not a rare disease for us. But we need to have a standard definition of rare disease, so that we can use an interoperability of the policy, and interoperability operability where some sort of policy changes for research and collaborations are applied across the regions. And this is why we also collaborated with Rare Disease International. ICD-11 is coming up. We had argued very strongly that definition of rare disease is included in the ICD-11 classification. And I'm happy to say that there is going to be a definition. The rare disease is now defined as a medical condition with a specific pattern of clinical signs and symptoms and findings that affects fewer than or equal to 1000 1 in 2000 persons living in any World Healthcare Organization defined regions of the world. That would contain Africa, America, Eastern Mediterranean, Europe, and Southeast Asia, and West Pacific. But we also want this particular type of definition get applied to India as well, so that we can also start using a very common definition throughout the world. And then people don't have to question whether this is a rare disease or not. And what is the way forward for all of us? One, of course, everybody, all of you are technical people. You already know, you are doing it in day-to-day practice. Antenatal treatments are already coming. You would have seen a lot of webinars or attended talks where miraculous treatments, miraculous progress have been achieved for a lot of lysosomal storage disorder by doing in utero enzyme replacement therapy. I think it is going to be the norm, provided we know that the genetic abnormality is already there. And if the genetic abnormality is missed, then we need to look at a more stronger advocacy for newborn screening. Government of India has already, as Dr. Khurana mentioned, there is a Umid project. Through Nidan Kendras, government is doing 10,000 pregnant lady testing, and also there will be testing for the newborns. And government of Delhi is already doing newborn screening for 6 rare diseases, and they are expecting it to roll out to multiple places as well. They are doing some pilot surveys there. I'm sure newborn screening is going to kick in more and more. And as we are going to look at the 10,000 genome project, we will get an idea of what are the types of pathogenic alleles which are present in Indian formulation, and we can have policy framed towards it as well. But we need to parallelly also support research and development in India. That's not only because we understand the kind of purchase power parity which is present in India, but also the situation that Indian patients are. A lot of the world patients are also going to be. So we need to develop rare disease drugs in India, for the world. Either we need to innovate means completely coming up with a new type of drug, or we need to come up with some sort of methods by which we can change the way the drug is absorbed. Like, for example, I'll give you the example. Standard example is Spinraza, which is an intrathecal drug for spinal muscular atrophy. Zolgensma, which is an intrathecal gene therapy for spinal muscular atrophy. But Risdiplam, which is coming from Roche, they just modified the same kind of ASO and made it orally absorbable. That has decreased the cost by a lot. Risdiplam you can get around 70 lakh per year, whereas your Zolgensma itself is going to cost, one single is going to cost more than 16 crore rupees. So that sort of innovation is important so that the cost can come down. There are more than 450 drugs which are out of patent now, out of exclusivity, and Government of India has also come up with a production linked incentive policy. Department of Pharmaceuticals has already come up with that, and that means that if anybody is manufacturing rare disease drug, they are open for and from the government is also going to provide money to the development of these kind of orphan drugs in India. And more importantly, I feel going forward we need to start understanding the value of the data, starting from, I mean, like, you guys are working, you guys are fetal medicine, starting from that level we need to ensure that the data is captured electronically. So prospective data should be captured electronically, retrospective data should be digitized and should be made machine readable. Just scanning is not going to be of use to us. That's the data which is scanned should be standardized, codified, so that anybody can do some sort of analysis and search on that. Just scanning retrospective data is not going to be of help. We need to be able to use the retrospective data, and prospective data, it should be made mandatory that we use prospective data, we record the prospective data in electronic format, and ensure that the prospectively coded data is also, prospectively entered data is also coded either through appropriate SNOMED CT terms, appropriate HPO terms, so that we can start doing some sort of analysis on them. And from the clinical trial perspective, I think there is a lack of clinical trial sites per se, because we get mails from a lot of CROs actually. For every month, one or two mails will be coming from CRO. They said, we are interested in doing research. We require this particular patient. Like just recently, I got a mail from a CRO. They are asking for beta thalassemia, and they want a specific type of genetic issue. And we had to actually score over four or five phone calls, 10 to 12 emails, and finally we were able to get that. Imagine if there are already established doctors network wherein we can easily reach out, this is the indication, this is the drug that is coming in the market, can we please start doing it? Because I understand, see, doctors, whenever you try to talk to them, most of the doctors, they say, this is my patient, these are my cohort, I don't want to give it to anybody. So Organization for Rare Diseases India believes that the we are not interested in the patient name or patient identification information, but we are interested to ensure that that particular requirement from a CRO or any other research company who are interested in getting these particular patients are connected to the doctors who is responsible for those patients. So we want to directly talk to those doctors who are interested in collaborating with the research firms or CROs who want to do clinical research on rare diseases India. And for that, we require clinical trial sites, doctors who are willing to be PIs, doctors who are willing to work with the clinical trial agencies, pharmaceutical companies or CROs, to ensure that the clinical trial on orphan drugs are done. 2006, there was a great time in India when a lot of clinical trials used to happen, but afterwards there was an issue in and lack of trust, which needs to be built up again, and say that Indian clinical trial can be India can also again get back to the clinical trial mode, but at the same time ensuring the patient safety and trust of the patient population is also regained. That is important. And from a research perspective, I think there is a huge need for GLP ready models. If there are there was one startup in Bangalore. They created a model for stem cell treatment for one of the rare diseases, and they wanted to test this particular stem cell treatment in a model system, because that is the requirement to apply for regulatory approval in India. And they didn't have any GLP model, because if the GLP model is not there, they cannot test their treatment, and they cannot submit regulatory. So they had to actually get out of India to do a GLP testing, which could have already easily been done in India. And that is just for one disease. A lot of rare diseases, like for example, Dr. Kurana was also mentioning that only 10% of the rare diseases have treatment. We have 9,000 more rare diseases for which treatment is yet to be found. And who is going to find them? And who is going to do the research on them? And what are the different types of model systems that are needed to to do the research for these rare diseases? So we all, and what are the model systems which are important that the regulatory also agrees to it? It is not like we can do a simple R&D and regulatory will apply and approve those model system research. It needs to be appropriately done in a regulatory compliant manner, for which there is a need for GLP ready models for rare diseases. And regulatory also understands that non-human models are catching up. In fact, FDA, US FDA has clearly told that they want to prefer non-human models. They want to prefer non-animal models also, so that as little animals are used for the research in developing orphan drugs. So there comes the iPSC model systems or organ on a chip model system. So those are the researches that are coming up, and for that we require people who are working directly, say who are doing amino day in and day out. You are seeing different types of cells, whether those cells can be used as model systems, whether those cells can be used as model systems and starting materials for creating newer and newer models. Those are some of the things we have to remember and see whether we will be able to contribute to it. And I invite you, we have National Rare Disease Helpline number. That helpline number, please note down. We also have an email which is always checked, and we always try to look out for helping patients, because we are patient organizations, patient driven organization and patient built organization. So our first priority has always been patient, but at the same time, when patients come to us, they always ask, where is the treatment, when will the treatment come, and who is doing the research? I want to fund this particular research. We have seen parents who are coming and saying, this is my home, I want to pledge this home, can you please develop a drug for my parent, for my son or a daughter? They are ready to do any type of sacrifice, but are we ready to take their sacrifice? That is the question that we need to ask ourselves. Thank you so much.
Thank you so much, Dr. Surendra Rao. It was truly inspiring and enlightening. I think we have all gathered so much of information from your talk today. We're really grateful to you for this. We now move on to our next session. We have some wonderful cases on rare diseases that have been judged and selected for today. For this, we have experts in the panel. We would request Dr. Sudhendra to continue as the expert, Dr. Ashok Khurana, Dr. Bimal Sahani, Dr. Aparna Sharma, and Dr. Bhavna Agarwal. So we now move on to our next session. The first case is presented by Dr. Gina Deca on arthrogryposis multiplex congenita with hydrops. So we have 4 minutes for presentation and 2 minutes for discussion. I would request Dr. Gina to kindly present her case.
Yeah, but this is slideshow. Just a moment. Okay.
You can move to slideshow mode, please,
Yeah.
Dr. Gina. Yeah.
Am I audible?
Yes, you're audible.
Good evening, everyone, and thank you for honoring me with this opportunity. So today I shall present a case on arthrogryposis multiplex congenita, presenting with hydrops at 20 weeks. So arthrogryposis multiplex congenita is not a separate disease entity, but is rather a descriptive diagnosis used to denote more than 400 individual diseases of varying etiologies. But the common feature in each of this is the presence of congenital, usually non-progressive joint contractures involving at least 2 different body areas. And that is arthrogryposis multiplex congenita. So they may be syndromic or non-syndromic, and over 400 genes have been implicated. So the prenatal ultrasound findings are typically joint contractures, that is decreased movement and fixed position of joints, and it can be associated with other findings like nuchal edema, hydrops, scoliosis, lung hypoplasia, micrognathia, retrognathia, or a non-visualized stomach bubble. So there is a Munich classification for AMCs, out of which the type 1 is just mere joint affectation, type 2 is with other system anomalies, and type 3 is the one which has got further neuromuscular involvement and lethal forms or intellectual disability like FADS. So my case is that of a 32 years female, spontaneous conception. Her NT scan was normal and she came for an anomaly scan at 20 weeks plus gestational age. So the salient prenatal ultrasound findings were subcutaneous edema in the fetal head and face, which was seen as increased nuchal fold thickness and increased prefrontal thickness. And the upper limb showed the wrists in hyperextension. The elbow was flexed and fixed. In the lower limb, the knees were found to be hyperextended, and the right foot was shown to have talipus, and the left foot showed fixed plantar flexion. The rest of the features was normal. The heart was normal. Stomach bubble was seen. There was no edema in the trunk. There was no fluid in the pleural and the peritoneal cavity. The spine was normal. The amniotic fluid was also normal, and the growth parameters were also normal. So ultrasound diagnosis of arthrogryposis multiplex congenita with hydrops was made. And so the next important part was counseling the patient. So whenever we get a diagnosis like this, the patient wants to know the etiology, the prognosis, as well as, any test that can be performed to find out the etiology. So the etiology of AMCs are usually intrinsic or extrinsic. So the intrinsic causes are genetic defects or congenital infections like cytomegalovirus, varicella zoster, rubella, or Zika. Even features of trisomy 18 can have arthrogryposis multiplex congenita. Maternal immune diseases like myasthenia can also be a cause. Then there might be extrinsic causes like congenital structural uterine anomalies like picornuate or septate uterus, uterine tumors, or multifetal pregnancies, which can cause this. And regarding the prognosis, whenever AMC is associated with hydrops or nuchal edema, polyhydramnios, scoliosis, knee joint fixed inflection, or absent stomach bubble, it usually points towards an unfavorable prognosis, and there might be intrauterine deaths. So the tests advised in these cases are usually amniocentesis with whole exome sequencing and torch panel, and this was done in our case as well. So the whole exome sequencing report came out to be a homozygous variant of uncertain significance in the SCN4A gene. And the disease inheritance was described as a congenital classic myopathy or congenital myopathy of the severe fetal form, which are autosomal recessive inheritance. So coming to the SCN4A gene mutation, the SCN4A gene is a skeletal muscle sodium channel gene, which is located on chromosome 17 and encodes the pore-forming alpha subunit of skeletal muscle sodium channel. And the mutations in this gene are associated with various neuromuscular disorders that are also labeled collectively as skeletal muscle sodium channelopathies. And OMIM has described these forms, that is congenital myopathies, hyperkalemic periodic paralysis, hypokalemic periodic paralysis, paramyotonia congenita, sodium channel myotonias, and congenital myasthenic syndrome. And also, this paper by Ravenscroft et al. Has described that for variants in genes which are critical to excitation-contraction coupling, like this SCN4A gene in our case, edema and arthrogryposis may be present, and edema may present as early as 15 to 18 weeks simultaneously accompanied by arthrogryposis. So with the advent of, whole exome sequencing being so frequently used, many other genes have been identified, and a very important one is the titin gene, where the severe prenatal or infant onset recessive titinopathies, which occurs due to biallelic titin variation, results in congenital titinopathy, and there is arthrogryposis hydrop sequence. And these are usually identified in the second trimester, which is accompanied by polyhydramnios. The reduced fetal movement begins in the second trimesters in titinopathy, which is followed by contractures, mainly distal. And the hydrops appear around 4 to 6 weeks later, and hydrops is usually extremely rare. And amniotic fluid changes, mostly polyhydramnios, usually occurs later in the third trimester. But in our case, it has been mentioned in literature that edema may present as early as 15 to 18 weeks, simultaneously accompanied by arthrogryposis. So the take-home message is that arthrogryposis multiplex congenita has wide phenotypic and genotypic variations. And as fetal medicine practitioners, we need to do a complete prenatal and postnatal investigations to identify an underlying etiology, provide information regarding its prognosis and inheritance, which is critical for the obstetric providers and families to optimize the pregnancy management and address future reproductive plans. So thank you so much for your patient hearing. Thank you.
Thank you, Dr. Gina. That was a marvelous presentation and really sets the platform and this forum for what we're going to be discussing this evening. You have unfolded for us how to handle cases like this, and you have set a fabulous trend. Thank you indeed. I wanted to ask you, so what is the counseling for this patient for this and future pregnancies?
So this was, I have usually SCN4, all these arthrogryposis are usually autosomal recessive inheritance. So that is what I've told her, like there's a 1 in 4, 25% recurrence rate, but she already has a earlier normal pregnancy. And so maybe regarding, before she plans, she can either go for an earlier diagnosis, with a CVS or something.
Yes,
When
excellent.
she conceives.
And so we really lit up the path for her and made sure that she has options in future pregnancies and she can always have a second baby.
Yes.
Thank you so much for that. Other questions from our experts?
I just wanted to ask doctor that there are some registry programs which are going on for arthrogryposis in France. So I was wondering whether you or have you seen anybody contributing to the registry of arthrogryposis in India or from India towards that?
No, I've not seen, sir.
Yes, we are not yet as active as we ought to be. And I'm so glad that we've got this opportunity today to have this program on rare diseases so that each one of us, 5,000 strong as we are today, now become active on the registries as well. Not just for recognition, not just for the sake of our patients, but to make sure that people with similar diseases all over the world get this opportunity to be aware of this information. And you've spearheaded all our wonderful work in the Northeast, and I suggest we take this forward in the form of these registries all over the place. And of course, as we discussed at our annual brainstorming session in Dholpur earlier this month, where all of us at the Central Executive Committee and all the presidents and secretaries of our regional chapters got together, that we really have to work out solutions for registries for ourselves as
Yes,
well.
sir.
We do have an overlap because several of us would report the same case since our patients often go for this, but this is really excellent as a starting point. Thank you so much. Any other questions for Dr. Decker before we close the discussion? Wonderful. And we have some questions from the audience as well. And we will take that up in the, if you could stay on, please, and we will take that up in the
Yes.
audience query session that Dr. Aparna will do for us after all the presentations take place so that we could put some of these questions together since there's bound to be an overlap. So over to our next case then.
So we have Dr. Dhaval Patel with dural sinus thrombosis. Dr. Dhaval
Hello.
Patel, if you could connect.
Hello.
Yes, Dhaval, we can hear you.
Okay, how to screen share, sir?
there
One
is-
screen option.
There is that icon at the bottom, which is highlighted in green with the
Yes.
top pointing arrow. If you click on that, you will be
Yes.
able to spot your screen share. Your PowerPoint would appear there. Then
There's a three option. One participant can share at time, multiple participant can share at time, and advanced sharing options.
So you take the one that's showing up your PPT.
Not click
Press.
on the arrow, direct on the share screen. Don't click on the arrow.
Don't click on the
Okay,
small
okay.
arrow. Go on the main big arrow.
Okay, this is the screen, no? Can you see my
Yes,
screen?
yes.
And now choose
Not
the screen
just
that you want to
choose
share.
that. Yes, yes,
Yeah,
yes.
yeah, yeah.
Excellent.
It's coming.
Excellent.
Okay, this is the my dural sinus thrombosis case, right?
Yes.
Um,
And click on that, and then We need you to go to full screen where you spot the full screen bottom right-hand corner. Yes, excellent. And now we see
Okay.
you and we can
Can
hear
you see
you.
my screen? Can you see my arrow?
Yes,
Yeah, yeah, yeah.
and we can hear you.
Okay.
Go ahead.
Okay. Thank you. Okay. Good evening, sir. Thank you. Thank you very much for giving me such a nice opportunity.
You
So
can
my
you can start your video also. We are not able to see you, Dr. Dhaval.
okay, sir. Video it's not working for me.
Actually,
Okay.
his camera is not working.
Okay,
That's
okay,
why
no
he's
problem, no
voice.
problem. Go ahead, go
Okay.
ahead.
Okay, this is the case. Is a 20-year-old female, Mrs. ABC, primi gravida, RH positive, referred for a second opinion for me at 20 weeks in view of posterior fossa cyst with echogenic mass. Her menstruation history is regular and LMP was A12 2022. Her family history is non-significant and medical history is a non-case of GDM. Coagulation profile was normal and no other medical significant. She is a obese patient, BMI is 29, non-consanguineous marriage and FT screen was negative. How to next slide?
Down arrow. Press down arrow.
Okay, okay. Her USG finding is single live intrauterine pregnancy of 20 weeks, 3 days. Head anatomy is almost normal except posterior fossa. In posterior fossa, there is avascular supratentorial hyperechogenic mass surrounded by the triangular shape apex anterior sonolution area, suggestive of dilated venous sinus with the thrombosis. Heart is normal. Final impression is dural venous malformation with the thrombosis. We suggested with the MRI of the brain. So here is a few images of the various sinuses of the brain, and there is a circulatory system and the brain start from the ICA intercarotid artery till to the IJV. So basically, dural sinus thrombosis as etiology is idiopathic, but abnormal embryological development in most of the cases, trauma, underlying systematic conditions such as the sepsis and meningitis, dehydration, hypercoagulopathy, inherited thrombophilia in fetus, anomaly or malformation in the venous system of the fetus, maternal PE, apply and smoking, and some cases of the placental insufficiency also take parts. So this is my video, and this video is a dural sinus thrombus. Is look at that the posterior fossa. This is the posterior fossa, and see this posterior fossa. This is the sonolution hypoechoic area, triangular shape, and this hyperechoic area is called the thrombus. And this thrombus is mainly avascular. There is no vascularity seen in this thrombus area, and see this is the other structures of the brain is normal. Is the corpus callosum and CSP, these third ventricle brain stems and vermis is almost normal. There is no any compression, such compression effects. So this is the 2D and the 3D image rendering. This 2D image is the size of the thrombus is almost 1 to 0.8 centimeter. This is a 3D image rendering. And here I am doing such a 4D volume of this thrombosis. It's just by transvaginal sonography because the patient is very obese. And I did the little bit try to see this posterior fossa in my 4D volume. Okay. So after that, we suggested the fetal MRI, and subsequently MRI start from the 21 weeks, 20 weeks, 6 days till the 32 weeks. See, in subsequently MRI, the mass and the fluid is regressing in size, and ultimately the outcome is postnatal is baby is delivered by C-section, some obstetric indication at full term. At 37 weeks, baby weight is 2.9 kg, female child cried well, and Abga skull was normal. Postnatal USG skull was absolutely normal, and her coagulation profile was normal. At present, she is a 6-month-old and doing well. So this is my normal for these images is a normal sinuses in the brain is a various sinuses. See, this is the straight sinus, is a dural sinus, superior sagittal sinus. This is the normal brain circulations in sag view. So clinical impact is a favorable outcome generally in 70% cases, especially when the clot regressing in size with the recanalization of the sinuses prenatally. But the some cases, like in these cases, in some cases, the local ischemic cortical damage due to some parenchymal hypoperfusion and compression leading to the poor neurological outcome or fetal demise is there. So the accurate diagnosis can be made by USG and you with the color Doppler and with the help of the MRI. Prognosis is totally depend on the size and location of the thrombus. Complications such as the cerebral edema, infarction, and hemorrhage impact on the neurological development may influence the long-term prognosis, and identifying and addressing any underlying cause or risk factors such as the maternal thrombophilic disorder or structural abnormalities. It can be important for them managing the condition and improve the prognosis. So the differential diagnosis is of course, the first differential diagnosis is arachnosis, intracranial hemorrhage and other causes. Of course, there is a dandioma malformation, AV fistula, and a vein of Galen malformation. So treatment in my cases, there is no specific therapy is available because it's just embryological etiology. And but we have to monitor these fetus by heart and see the thrombus size and the posterior fossa fluid area. If the brain is appear normal, this reassure the parents, and good prognosis marker in this case is the decreasing size and presence of the clots. But in in other hand, there is a poor prognostic markers in suppose there is a ventriculomegaly or any parenchymal brain injury was there. Size of mass at diagnosis is not predictive of the outcome. So this is the protocol of the posterior fossa mass with fluid. If any there is a mass in posterior fossa with enlargement of the intrahemispheric space and stasis or interruption of the blood flow, thrombosis of the posterior sinuses, there is a two possibility: brain damage or cardiac failure, or no brain damage or cardiac failure. Suppose the brain damage or cardiac failure in these cases is a totally unfavorable prognosis, but no brain damage or cardiac failure is there. The MRI is suggested, and the deep thrombosis or brain damage or dural sinuses malformation with the atrioventricular shunt was there. That means again there is an unfavorable prognosis. But no deep thrombosis, no brain damage, no AV shunt suspected. So we put this fetus is or put this pregnancy in close surveillance, serial ultrasound and color Doppler with MRI. There is a three possibility. Suppose the cardiac failure in later gestational or secondary brain damage was there. That means there is unfavorable prognosis, no decreasing thrombus in size, and absence of the fetal decompensation or brain anomaly. That is unpredictable prognosis. But there is a partial or total regression, no sign of fetal decompression. In these cases, generally is a favorable outcome. Thank you, sir. Thank you very much. Hello.
Excellent, Dhaval. Very, very nice images and a very interesting case indeed. And of course, the lesson that masterly inactivity in the perspective of knowledge can help a very decent prognosis. There are two questions which are directly related, and perhaps we could take those now. And one is that in addition to monitoring the thrombus size, and in this, what could be the other roles of fetal MRI, and whether you did a postnatal MRI.
Still the patient didn't do this postnatal MRI because the skull USG skull is absolutely normal. So we continue follow up this patient, and patient will come around March and April in my town, and especially to meet me, and I will suggest do the MRI.
Excellent. And
because in this is the sir teamwork, and fetal medicine specialist, obstetricians, of course, Fetal madam is there in my team. So basically positive counseling and leads to the good outcome, this particularly this fetus, because there is a very rare dural sinus thrombosis cases in this case.
Wonderful. And was the thrombophilia workup done postnatally?
Yeah, of course, this is normal. The coagulation profile is in pregnancy also, mother is normal, and postnatal fetus is baby is also normal.
Dr. Dhaval, what was the frequency of surveillance? How frequently should one monitor them?
So 4 weeks. In my case, 4 weeks. Because no any other decompensation compensation features. The heart is absolutely normal. There is no the thrombus is also avascular. There is no any brain hemorrhage or brain ischemic changes in cortical or any brain parenchymal injury. So 4 weeks, sir.
Excellent.
Thank you.
Thanks very much.
Okay.
And can we move on to the next one then, perhaps?
Yeah.
So our next case is Dr. Vidhi Hati, who's presenting on gestational alloimmune liver disease. Dr. Vidhi.
Good evening, everyone. I'll just share my screen. Is the screen visible?
Yes, ma'am.
Good evening, everyone. Thank you for the opportunity to present today. I am Dr. Vidhi Hati, and today I have a case of a gestational alloimmune liver disease. So this patient was a 35-year-old Rh positive, third degree consanguineous marriage. She was a fifth gravida with 3 losses and 1 medical termination of pregnancy. The first 2 pregnancies, the baby was diagnosed with harlequin ichthyosis after birth, and the baby died. After the second pregnancy, the carrier status, the neonatal testing was done, carrier status was confirmed for the parents. In the third pregnancy, a CVS was done, and the fetus was unaffected. This was the term which I, however, also for some reason died at day 10 of life with the diagnosis of hemochromatosis. In the fourth pregnancy, there was an antenatally confirmed harlequin ichthyosis, and that pregnancy was terminated. And she was then now at her fifth pregnancy, in which was also normal. She had been advised to routine follow, and she came to us at the target scan with all this history. I am not sure how to. I'm unable to move the slides.
Just take the cursor in the center and then press.
Just click
Okay.
on the screen anyway, yes.
Yeah.
Yes.
Okay. Yeah. Okay. So at the first visit, we did a target scan. The anatomy assessment was normal. There was only an aberrant right subclavian artery. Second visit was the same. Third visit was 32 weeks, where we found some intrauterine growth restriction. Estimated fetal weight was at the 4th centile, but the uterine Dopplers were normal, fetal Dopplers were normal. Everything else looked okay, and we hence suggested follow-up after 2 weeks. We were expecting a good outcome this time. Well, so she didn't follow up at 2 weeks, but came back again to us at 35 weeks and 4 days. And there was IUGR. Weight was again at the 4th centile, but the Dopplers were extremely abnormal. And we had an umbilical artery showing high resistance, as well as absent, as well as reversal of flow. The ductus venosus was high resistance. The MCA PSV was actually quite high. It was 1.7 to 1.8 mom, and which were all not matching to the degree of growth restriction. So we thought that maybe it is in a hyperdynamic circulation. And in addition, there was placentalomegaly, there was hepatomegaly, there was splenomegaly. We were stumped with these incongruent findings. Was it a metabolic disorder again? Was it a fetal infection? Was it a fetal anemia, non-Rh related, since she was an Rh positive mother? Or that small possibility of a recurrence of hemochromatosis in this pregnancy? But for most of these, the genetic, a whole exome had been performed. Her whole exome was normal. So we reviewed the exome report again with the lab. There were no variants that we had missed, which had not been reported earlier. We reviewed the prior pregnancy records. Autopsy, there was an autopsy actually done on review, we found, and the autopsy had confirmed hemochromatosis causing death in the neonatal period. And hence we reviewed the literature again. And then we realized that hemochromatosis, unlike in childhood, hemochromatosis in the neonate is not a genetic disorder at all, but an alloimmune liver disease. And it is actually mediated. So we know of the 2 common alloimmune disorders, the Rh isoimmunization and the much rarer alloimmune thrombocytopenia. But there is a rare third cousin also, where the maternal antibodies actually damage the fetal liver cells, causing hemochromatosis, causing liver injury in the fetal life, and neonates present in this gestational alloimmune liver disease with severe liver failure at birth. And this is and they have a course, die with a few days, and the disease is commonly diagnosed only at autopsy. Invariably, it is missed in the antenatal period. Antenatal findings are actually non-specific with intrauterine growth restriction, oligohydramnios, sometimes unexplained demise in the late second or third trimester, rarely hydrops, fetal anemia, organomegaly, or placentomegaly. And the scary aspect is that the recurrence rate, because it is an alloimmune disorder, the recurrence rate is 90% in subsequent pregnancies. So if not diagnosed in time, the prognosis is dismal because there is severe neonatal injury, neonatal liver injury, and the antibodies keep acting and the baby dies within a few days of life. However, if we suspect it antenatally, postnatal care is with immediate immunomodulatory therapy in the form of exchange transfusions or IVIG at birth to prevent the ongoing liver damage due to maternal antibodies. And a timely diagnosis and intervention actually improves the survival in this disease from 15% to 85%. Is antenatal treatment possible? Yes. For prior affected pregnancies, maternal IVIG can be considered for prevention from 14 weeks onwards with a weekly maternal IVIG. So for our case, we now were reasonably sure that this is a recurrence of the hemochromatosis that was there in the third pregnancy. We alerted the neonatology team to the possibility of gestational alloimmune liver disease. The baby she was already 36 weeks, Dopplers were grossly abnormal. We delivered the baby next morning by elective C-section. Immediate IVIG was given at birth. The baby had hepatosplenomegaly, thrombocytopenia, and hyperbilirubinemia at birth. Exchange transfusion was done on day 2 of life in view of worsening hyperbilirubinemia, and one more IVIG was given post the exchange transfusion. The lab parameters, the liver function parameters started improving day 3 onwards. An MRI done at 2 weeks of life confirmed severe iron deposition in the liver and kidneys. Final diagnosis is by biopsy, and the biopsy is still pending. The baby is on regular follow-up since the last 2 months and has not had any liver dysfunction so far, at least. Thank you.
Thank you very much, Vidhi. That was beautifully worked up
Hmm.
and excellent piece of knowledge for all of us and very well presented. Any questions from our...
Nidhi, was there any connection between ichthyosis and hemochromatosis?
So no, not really. This was a double whammy for the family. There was a genetic disorder along with an autoimmune disorder, an alloimmune disorder. We actually searched literature and there was no connection there.
Yeah. Because 2 cases, first and second, and then we come down with 2 pregnancies with the same, with something else.
Yes.
Maybe
and we were actually waylaid by the strong history of a genetic disorder, never suspected that there could be something else.
Yeah.
So very nice, Dr. Vidhi. I just wanted to ask one question. Do we have the ALT and AST parameters available? Because as I know that GALD is the most common cause of neonatal liver failure, followed by infections in the form of HSV. So it's not that uncommon in the neonatal setup, vis-a-vis in prenatal that we are saying that it's uncommon. So do we have those parameters available? Because as I know that these parameters are less likely affected. And this is one of the distinguishing factor between this cause of neonatal ALF versus other causes like metabolic causes, which we were talking about, which you were wanting to rule out. So just wanted to, for the betterment of this particular topic, to highlight these 2 things, if it is available.
So yes, that was actually, I don't have the exact reports right now, but that was actually exactly the case. Only the bilirubin was high, AST, ALTs were okay, AFP was high, ferritin was high.
Yeah.
And yeah.
So that is
So
a quick a distinguishing factor if we want to distinguish between the other causes of neonatal ALF versus GALT, as you are also saying the same. So very nice. And one message by your talk is we have two disorders, one acquired one or the other is genetic. So we should keep our eyes open in such a pedigree in front of us. And even two genetic disorders in one family happening is also happening. So yeah, very nice case. Thank you.
Excellent. So before we move on to our next case, I'd like to take this opportunity to let everyone know that we had thrown open abstracts for this particular program to every member, and they had sent in the abstracts. We received over 20 abstracts, and we had six reviewers for these abstracts, and I'd like to express our appreciation to Dr. Sangeeta Gupta from Delhi, Dr. Aparna Sharma, who is a National Secretary, and Dr. Krishna Gopal, who is, everyone knows him, he doesn't need an introduction, Dr. Alok Vashne from Delhi, Dr. Gorika Sai from Delhi, and Dr. Meenu Batra from Kochi. And I would like to thank them for having judged these. And then we've chosen the 11 top of those. So the other thing is that all of these will pre-qualify to be published in our Journal of Fetal Medicine, to be fast-tracked, because they're all well worked up cases. So do remember to send them in before you do anything and relegate them to some far corner of your catalogs and they are lost to posterity. We don't want that to happen. Before we go on to our next case, if we can have our trade partner videos again, and then we come back to our next case for presentation and discussion.
Can we cover that? There is one case, there is one report by Renick et al. For this, wherein they were actually hunting for the elusive target antigen in the gestational autoimmune, liver disease. I can probably paste that. It came out in October 2023. Despite of all their efforts, they were not able to actually find an alloantigen. That is the very interesting aspect of it. And at the end of the say, they say that maybe it is not some antibody that is it's not the antigen which is kind of triggering this, but there could be some other mechanisms wherein the the fetal itself would be having abnormality antigens and antibodies that are coming up. So the specific wording is that let me just tell you, I was reading that. They say that it seems unlikely based on our results that the GALD antigen is an alloantigen, and we favor the hypothesis that the antigen is exclusively expressed during fetal life in all pregnancies. So that is the thing. So I am wondering whether Dr. Vidhi should take this kind of research forward, probably talk to those people and further the research in this GALD, because this case is very unique and very interesting, and I learned a lot as well.
Yes, sure. So thank you.
We move on to our next case. Dr. Ravinder Kashyap will be presenting a rare case of fetal hemochromatosis. Dr. Ravinder Kashyap.
Thank you, ma'am. Good evening, everyone. And thank you, SFM, for giving me this opportunity to present my case here. This is a companion case to the previous case presented by Dr. Vidhi. And the case I'll be presenting is the fetus in trouble, a rare case of fetal hemochromatosis. But the only difference here is that we were able to provide the diagnosis in primary gravida and with the help of another imaging modality, that is prenatal MRI. This was a 23-year-old primary, non-consanguineous marriage. She had an Rh positive blood group. Her first trimester screening was low risk. Her anomaly scan done elsewhere was normal. And she was referred to our center at 29 weeks of gestation with features of oligohydramnios, IUGR, and echogenic bowel. And she had no other comorbidities. On ultrasound done in our center, there was left axis deviation of the heart with prominent right-sided chambers. And Unusually, there was hepatomegaly with coarse liver echo texture and features of fetal growth restriction. In order to investigate this coarsened liver echo texture further, we subjected the patient to fetal MRI. And on MRI, the T2 weighted coronal sections of the fetal thorax and abdomen shows hepatomegaly with intensely hypointense signal intensity of the liver, and there was associated splenomegaly. And these are the T1 weighted coronal images of the chest and abdomen showing intense hypointense signal intensity of the liver. And here we can see the T1 hyperintense bowel loops for comparison. And these are the normal images for comparison. And this is the image of our case. This is the signal intensity drop of the liver. And this is the normal liver signal intensity on T2 weighted images. And these are the T1 weighted images. This is the normal for comparison. Here you can see that a normal liver appears hyperintense on T1, whereas in our case, it was significantly hypointense. And on coronal images of the head and neck, this is the normal image for comparison. Here we can see the normal hyperintense signal of the thyroid gland. And this was absent in our case, which suggested the presence of iron overload in thyroid gland. So we're putting these features together, we arrived at the finding of fetal hemochromatosis. This terminology has not been described in the literature. However, we considered this to be a case of iron overload in the fetus. And the differential diagnosis for this appearance is, as highlighted in the previous case, GALD is the most common cause, accounting for 95% of the cases. And we have other, the 5% of these cases can be caused by other causes like infection, trisomy 21, single gene disorders, and syndromes like trichohepatoenteric syndrome. Amniocentesis was done, karyotyping was normal, Torch and parvovirus PCR were negative, and she was followed up with weekly follow-up for Doppler, and the prognosis was, the couple were counseled about the poor prognosis of the condition, and she was delivered by elective LSCS at term. Postnatally, the baby had hepatosplenomegaly with features of hypoglycemia, deranged LFT, thrombocytopenia, elevated ferritin, dysmorphic facies, and the baby was suspected to have neonatal hemochromatosis or gestational alloimmune liver disease. And the postnatal MRI also confirmed the findings of iron overload in the liver and the thyroid and features of cirrhosis. These are the gradient images of the postnatal MRI. And a lip biopsy was performed, and a pulse stain of the biopsy specimen showed a blue staining of the iron, which is highlighted over here in the acinar cells of the glandular epithelial cells, which indicates the presence of extrahepatic hemosiderosis. And a rapid exome showed a variance of uncertain significance, likely compound heterozygous variants of autosomal recessive inheritance in the SKIV2L gene, and further testing is required. Liver protective measures were started for the baby. Serum IVIG was administered, but unfortunately, we lost the baby at 2 months of age due to respiratory failure and complications of liver failure. So gestational alloimmune liver disease, as previously mentioned, is a disease caused thought to caused by the antibodies crossing over from the maternal serum to the fetus, damaging the fetal liver. And the ultrasound features include fetal growth restriction, oligohydramnios, ascites, splenomegaly, and irregular liver echo texture. An MRI here can help us to clinch the diagnosis prenatally with features of atrophic liver and the presence of iron deposition, splenomegaly. But the pathognomonic finding would be the immunohistochemical staining for C5b9 complex, the neoantigen created by the action of this complement on autopsy. However, in our case, the parents declined autopsy. And as highlighted previously, the recurrence risk is about 90% with mortality in the fetuses of a mortality rate of about 70%. Hence, the only options remaining would be serum IVIG in the subsequent pregnancies antenatally, or the couple has to go for surrogacy. The other condition that we encountered in our case is the trichohepatoenteric syndrome. However, it was a variant of uncertain significance. It is an autosomal recessive condition with features of IUGR, intractable chronic diarrhea, woolly brittle hair, immunodeficiency, liver disease, dysmorphic facies, skin pigmentation. However, the phenotypic genotype correlation was not so strong in our case because of the lack of symptoms like chronic diarrhea and woolly hair. And this is caused by a biallelic pathogenic variants in the SKIC2, SKIC3 genes. There are two genes thought to be causing this disease. And so far, 50 cases have been reported in the literature. And the role of fetal MRI in these cases would be the quantitative assessment of organ iron deposition, which is possible in adults population using T2-star relaxometry, can be extrapolated to the fetal population as well. And the fetal MRI can help assess clinical response to in utero treatment when we start serum IVIG in the subsequent pregnancies. And for this purpose, the in-phase and post-phase signal intensity ratio of the liver can be calculated in suspected cases, and it has been shown to improve in cases of in utero treatment. And in cases of T1 weighted images, it can help to assess iron overload in intrinsically hyperintense tissues like our liver and thyroid. And it also plays a role in postmortem evaluation when the autopsy is declined by the parents. So to conclude, fetal hemochromatosis is a condition that is suspected on ultrasound, but can be confirmed on fetal MRI readily. And the most common cause being GALD. However, we also need to remember that non-GALD cases also account for 5% of these cases, and they include genetic causes. And more studies are required to know the possible underlying genetic causes of this condition. And it has to be remembered that it is a poor prognostic condition with high risk of recurrence. Thank you for this opportunity.
You can unshare your screen, yeah.
Yes, sir.
Thank you, Ravindra. Very nice case. So we got two back-to-back cases. So much to learn from these two cases. And probably with both the cases have a different perspective, but probably the differential and everything comes over in the same form. If you would have done this whole exome prenatally, would have landed into much more confusion at that time with the with the VUS that you got here. Bhavna probably would say something on that, but good follow-up, good case. Thank you very much.
I wanted to add one point, Dr. Sani, in this. So when these kind of cases get published, I think this case by Dr. Kashyap clearly highlights that we should also provide some negative information also, not only but positive information. In the when you're publishing this, like you actually looked for, you got a VUS, but there was a genotype phenotype correlation was not there, so that when we try to do an ACMG classification for the pathogenicity at a later time point, this kind of negative data also is taken into account. So it is important that you provide both positive and negative information, not just when you're publishing just wherever it fits. That it will be really helpful.
Thank you, sir.
Important message, very important message. Rima, we moved. Yes.
Okay, we move to the next case. So thank you so much. Our next case is by Dr. Dhaval Patel again, a case of cystic fibrosis. Dr. Dhaval, could we have your screen sharing,
Yes,
please?
yes.
Thank you.
Yes. Can you see my screen? This is totally black out here.
Because I think it's on end of your slideshow.
Yes.
Maybe you need to click on your first slide and then start it. So you'll have to
End of
unshare.
the slide, so click the exit.
Yeah, go up. Yeah.
Yes. And open the correct one that you need. That's right.
Can you see my slides and arrow?
Yes.
Okay, this is the case of the cystic fibrosis. It's a Mrs. X, 29-year-old, second gravida, 21 weeks pregnancy, came for the second opinion for me is a echogenic bowel with intestinal obstruction and non-visualization of the gallbladder. FTA screening was normal. My colleague Dr. Jitendra Patel and my colleague Dr. Otsa initially screened this case and they sent me the second opinion. My USG finding is non-visualization of the gallbladder with echogenic bowel, PAMC seen, CMV IgM positive, no other abnormalities seen. So counseling the patients regarding this anomalous finding and plan for the invasive procedure with FIS, torch PCR from the amniotic fluid and whole exome sequences. So this is my image. In this left side, there is a nicely left portal vein seen. This curve is the X, is a portal circulation, but in this area, there is a no gallbladder seen. Again, this is the dilated bowel loop. This is how much, this is the big dilated bowel loop. And the right side, there is an echogenic bowel. It's look like a meconium ileus. Here is a PAMC scene, and this is the meconium ileus look like, and this is the portal circulation, but there is a no gallbladder. This is the video. This is the abdomen circumference. See, this is nicely curve of the C curve of the portal vein, but this area is a no gallbladder. Stomach is nicely seen. Here is a echogenic bowel with dilated, minimal dilated bowel loops is there. In periphery, again, I start the color and see this is slow flow. It's nicely portal circulation seen, but this area is empty. There is a no tubular avascular structure is seen. It's called the non-visualization of the gallbladder. So after 1 week, again I see this seen this patient, but same finding. So I was thinking about the MRI. So I suggested this patient to do MRI and see the MRI for the abdomen pelvis. And this is the MRI volume. This is the abdomen bowel. There is a no gallbladder seen. Meanwhile, we did the amniocentesis after MRI and send the report for the FIS, torch PCR because the IgM CMV positive and the whole exome sequences. See, this is no gallbladder. So this is the report, genetics report. The FIS is negative, torch PCR is negative, but the in whole exome there is a CFTR gene is positive. So this is the cystic fibrosis straightforward case. Role of digestive enzyme still debatable in this diagnosis. So let me some focus about this enigma of the testing or role of the digestive enzyme from the amniotic fluid in view in case of the perinatal non-visualization of gallbladder. The digestive enzyme mainly in amniotic fluid in this case is a gamma-glutyl transpeptidase and a leucine aminopeptidase before 24 weeks can be the good indicator of prenatal bile duct damage, but it still remains to be proved. These digestive enzymes synthesized by the biliary epithelium and by enterocyte, they are present from the in the amniotic fluid from the 12 to 13 weeks of gestation and then gradually decrease to the 24 weeks for the progressive maturation of anal membrane that became impermeable to the digestive secretion. After 24 weeks, these enzymes are lower concentration in amniotic fluid, and that's why very difficult to differentiate between the abnormally low or lower physiological level, although high value permit to excluding the biliary atresia and cystic fibrosis. So amniotic fluid digestive enzyme analysis can be considered only as an experimental tool and certainly not as a part of the clinical evaluation of the perinatal non-visualization of the gallbladder at present. In biliary atresia, amniotic fluid level gamma glutyl transpeptidase is dropped dramatically after 16 weeks of gestation, and whereas the cystic fibrosis cases and intestinal atresia cases, level of the all digestive enzyme fall sharply. So at USG 15-18 weeks failed to detect gallbladder and amniotic fluid digestive enzyme value below the fifth centile, this scenario can be chances of biliary atresia is high. So this is the protocol. If in case of the non-visualization of the fetal gallbladder, a routine ultrasound, repeat ultrasound after 1 week. If the visualization of the gallbladder is seen, then this is normal USG follow-up reassurance this patient, but confirm non-visualization gallbladder again after 1 week or 10 days. So there is the role of the amniocentesis. First of the detailed ultrasound should be done to rule out the other extra GI or intra-GI anomalies. Amniocentesis should be done, and the prenatal screening for the CFTR gene mutation should be offered. So in amniocentesis, we find out the karyotypic of FINS, cystic fibrosis genes, and the digestive enzyme analysis suggestive for the biliary atresia. If there is no this about if the FIS is negative, cystic fibrosis negative, and the digestive enzyme is negative, that means there is no any abnormality. Still 10% cases there is a risk of the biliary atresia, and we offer the patients for the termination because biliary atresia is a caught is a life-threatening condition, and immediately Kasai surgery should be done. But if these things are positive, cystic fibrosis positive, then prenatal counseling and consider of the pregnancy to the termination. So cystic fibrosis is an autosomal recessive condition, multisystem disorder caused by the dysfunctional chloride ion transport across the epithelium surface, and the CFTR gene mutation, if positive, then that is a lack of the chloride ion secretion and increase the sodium retention and fluid absorption. So they increase the viscosity of the luminal secretion and obstruct the duct of the solid organ and the hollow viscera. So discussion in this case is the gallbladder with the stomach and the course of the umbilical vein is one of the main landmark of the fetal abdominal anatomical structures. Color Doppler is useful to differentiate from the non-vascular structures. Gallbladder can be visible at the prenatal ultrasound from 13-14 weeks of gestation as pear-shaped structure with the echogenic wall visualized in the right anterior superior quadrant of the fetal abdomen. Non-visualization of the fetal gallbladder is a rare, about 1 in 2,000, but associated 40% with other severe fetal anomalies. In case of the non-visualization gallbladder, the scan should be repeated after 7 to 10 days. So consider is the normal ultrasound exam doesn't rule out the cystic fibrosis. Echogenic bowel meconium ileus is present in 20% cases. Negative carrier screenings lowers but do not eliminate the risk, and meconium ileus may be indistinguished from the ileal atresia. So the workup for cystic fibrosis in fetal bowel obstruction. Thank you, sir. Hello.
Just stop the screen share, sir.
Hello.
Thank you, Dhaval. That was another very interesting case. Any questions or remarks from our panel?
No, the only thing I want to say is that For many years, we lived with this notion that cystic fibrosis is something that in India we don't need to worry about. But I think that's now gone for a toss. We have a decent prevalence here, and hence a combination of when you're finding an dilated bowel loops or echogenic bowel with an absent gallbladder, always keep that in mind. Very important thing.
I wanted to add one point, sir. For the cystic fibrosis patients, we also require multiple specialty treatments. Manipal Hospital in Bangalore, Dr. Eileen Kinemi will be starting cystic fibrosis multiple specialty clinic very soon. So if you have any patients who require that, you can actually send it to Dr. Eileen Kinemi at Multiple.
Thank you.
Okay, thank you, sir.
So we move on to our next case.
So our next case is Dr. Sonal Gupta will be presenting on antenatally diagnosed Tay-Sachs disease. Dr. Sonal Gupta.
Yes. Am I audible?
Yes.
Hello, everyone. And today I'm going to present a case in which usually ultrasound is normal. And if we do not look at the history, at the possible options of diagnosis, then we can pass it as a normal case. So this is a case, antenatally diagnosed case of Tay-Sachs disease. Tay-Sachs disease is an inborn error of metabolism. It's a rare lysosomal storage disorder. The important point here is it neither has a cure nor prevention. So that's why antenatal diagnosis is very important. It's actually an autosomal recessive disorder resulting from mutation of hexa-A gene encoding the alpha subunit of lysosomal enzyme beta N-acetyl hexoaminidase A, which is located on chromosome number 15. There are three types of presentation in Tay-Sachs disease. The commonest one is in infantile stage, that is classic infantile, which mostly presents when the children develop symptoms within 6 months of age. The other two, where the presentation is in the juvenile age or late onset adult age, are relatively rare. In the juvenile form, usually the symptoms appear from 5 years to teenage years. In the late, usually they start in the teens or early adulthood. The late onset type usually do not lead to mortality, but affects the life and it's highly morbidity. Looking at the clinical symptoms, it is usually
slides not moving. Please do in full screen mode and slideshow.
Can't you see the second slide?
No, ma'am.
Okay, I will go again. Now, can you see the second slide?
Yes, ma'am, but not in full screen.
In full screen.
You know where at the bottom
This
right?
isn't full screen?
No, where the bottom
No.
right it says 73%. Right next to it is that full screen icon. You can do that, or you can go to slideshow, whichever you prefer.
Now? Now it is full screen?
No.
No, ma'am.
No. Okay, wait. Just give me a minute.
Ma'am, you have shared the unfull screen mode. You have already shared, did the full screen mode, but that is not shared actually. So you can just move the slide or change the tab to that.
Okay.
Just try pressing F5. It will get to full screen. F5.
F5.
Yes.
Just a minute, ma'am. Here I will hold. Now is it visible? The full screen?
No, ma'am.
It's okay. It's okay. You can change the slide manually. Yeah.
Yes. Yes.
Yeah.
Excellent. Yeah.
Now we can see the second slide.
Yeah.
You can see the second slide?
Yeah.
Yes.
Yeah. The clinical presentation usually starts in infancy by neurodevelopmental retardation, followed by paralysis, dementia, and blindness. The average life expectancy of Tay-Sachs disease is 4 to 5 years only. although the rare late onset cases have been reported reaching up to 47 years of age. It affects 1 in 320,000 people. So we can assume that how rare it is, and the life expectancy is too less in most of the cases. Usually the clinical symptom starts with muscle weakness, delayed milestones, which start in the 4th or 6th month of age, which progresses to seizures and dysphagia. The child gets startled by loud noises. There is loss of vision and loss of hearing. Here I would like to add one thing, that what do I mean by loss of vision and loss of hearing? This is a progressive neurodegeneration, which means that the milestone that the child has already attained, gradually they starts losing. The child had the vision and there is loss, gradually there is loss of vision. The child had the hearing and gradually it gets lost. On fundus examination, there are cherry red spots in the eyes. Usually the cause of death is recurrent respiratory infection and pneumonia. There is loss of previously learned skills. Mood and behavioral changes are very common, and in late onset chronic type, there are many psychiatric abnormalities, mood abnormalities, and behavioral abnormalities, though there is less chance of mortality. The differentials, the related diseases are commonly those which are having lysosomal storage disease like presentation, like AB variant gangliosidosis or send-off disease. Send-off disease is caused by mutation in HEX B gene, while TASEC is in HEX A gene. Of all these three common differentials, TASEC disease is best characterized with over 100 known mutations in HEX A gene. So now my case, regarding the case, this patient was a 4th gravida, G4P2L1A0. Importantly, the marriage was consanguineous.
Please change the slide. Slide is not.
Again, it is not visible.
Yeah, ma'am. Yeah.
Now?
Yes, ma'am.
Okay. Sorry for this interruption. It's a G4P2L1A0 pregnancy, consanguineous marriage, a Muslim couple with history of death of 2 offspring, one at the age of 11 months and another at the age of 5 years. Both the children had presented with global developmental delay, tonic-clonic seizures, EEG abnormalities, and elevated circulating alanine aminotransferase concentration. One of the baby had some ultrasound features like macrocephaly, hypertonia, delayed closure of anterior fontanelle, temporal epileptic form abnormality on EEG, and postnatally MRI was done, which showed spectroscopy showing possibility of leukodystrophy or metabolic disorders. These were all suspicion postnatally. No genetic workup was done in the previous pregnancies. So when the patient approached us in the when she was 4th gravida, to start with, we did genetic counseling, explained the patient regarding the possibility of neurodegenerative disorder having genetic basis. And then we did next generation whole exome sequencing of both parents first. We found a same heterozygous variant in mother as well as father in HEX A gene mutation. This was a reported variant in population databases, that is genome AD, TGP, and 1000 genome, or in ClinVar. The variant is reported to cause a shift in the reading frame, thus leading to nonsense-mediated decay. This was confirmed in the Sanger sequencing of parents 2, and a similar heterozygous variant was found in Hexa gene. Followed by this, we did Sanger of the amniotic fluid. We did amniocentesis and did Sanger of the fluid at 19 weeks, which showed homozygous mutation. Same mutation was found in a homozygous state, which was in a heterozygous state in the parents. This was previously reported disease-causing mutation. So we were able to give final report by 21st week of gestation, and parents were counseled regarding bad prognosis of the fetus. But yes, the autonomy prevails and they decided to continue the pregnancy, considering it as a last chance, because the previous 2 losses were already because of in that case she had already lower section cesarean section, so this was her last chance, and she decided that she will deliver this baby and she will accept it whatever the fate. Anomaly scan was done, and I have not included any ultrasound image because throughout anomaly scan and all the scans were normal. There was no ultrasound abnormality. She delivered a 3 kg female child at 36 weeks on 1st August 23. The baby is normal till date. Now the baby is 7 months and there is normal developmental milestones. There is no developmental delay and has attained all the milestones for the age. This indicates that yes, it is not an infantile form, but it can be a juvenile or late onset type of disease. The case is under observation and follow-up. Thank you.
Thank you, Sonal. If you can unshare your screen, please.
Yes, yes, sir.
Any comments from our experts?
Sir, if I can add one point.
Yes,
yes.
So, Dr. Sonal, good case presentation. Only wanted to add one point that since the mutation profile which you showed, the genotype-phenotype correlation says that if we have 2 null mutations for this particular disorder, it's going to be early infantile form rather than the juvenile or late onset form. So it's going to manifest soon. One thing.
Yes.
The intrafamilial variability is there only in late onset or juvenile. Like both of them they can interchange. And other thing is we are not expecting any prenatal finding in Tay-Sachs. So it's actually I would say failure on the part in the second pregnancy itself. Then when the counseling was not done in the form of testing in the previous child if it is available, or couple exome sequencing. But yes, we did all the efforts in this pregnancy. However, because of the religious reasons, they chose to continue the pregnancy. We respect that decision. So, but just these 2 points I wanted to highlight. Thank you.
Yes, thank you, ma'am.
Thank you. Should we move on to our next case?
Thank you, sir.
So next case is being presented by Dr. Navya, an interesting case of binders associations with GNP TAP mutation, a metabolic syndrome. Dr. Navya KC.
Hi everyone, I'm just sharing my screen.
Excellent.
A warm evening, almost warm night to everyone. I'm Dr. Navya, consultant fetal medicine, Yashoda Hospital, Hyderabad. I'm going to present about a binders association with a rare metabolic syndrome, that is lysosomal storage disorder. We know that binders phenotype is a rare developmental defect. By definition, it is a hypoplasia of central portion of the face, that is maxillonasal hypoplasia. There are a lot of synonyms like binders syndrome, phenotype, maxillonasal dysplasia, or dysostosis, nasomaxillary hypoplasias. It was first described in the medical literature as far back in 1882. But Dr. Noes described these essential features of maxillonasal dysplasia in 1939. But detailed features were first described by binders in 1962. We all know this. And the prenatal diagnosis of BP was first published in 2000 by Cook, who described as prenatal definition as flattened nose, reduced FNA, that is frontonasal angle, and protrusion of the maxilla. So the clinical definition of BP, which is composed of 6 characteristic binder phenotype, was developed in 2010, where it said that there will be a Raynaud face, abnormal position of the nasal bones, intermaxillary hypoplasia, malocclusion, reduced or absent anterior nasal spine, atrophy of the nasal mucosa, and absence of the frontal sinus. Thus, binder phenotype is a rare structural anomaly, has a genetic component, but with no clear inheritance pattern, with etiological heterogeneity, and with a place for environmental factors. This slide shows the literature where with binders associations, like the etiopathogenesis of binders phenotype, which could be a teratogenic or environmental factors, like most commonly vitamin K deficiency with vitamin K epoxy reductase deficiency, maternal exposure of phenytoin and rubella, most commonly associated with maternal autoimmune diseases, and it could be due to deficiency of early trimester vitamin K levels like hyperemesis gravidarum. etc. It could be due to chromosomal aneuploidies like 21, 18, and Turner syndrome. And other single gene disorders are also associated with binous phenotype like chondrodysplasia punctata, autosomal recessive chondrodysplasia punctata, and other types like telomphalangic chondrodysplasia punctata, and other syndromes, Stickler syndrome, and etc. And there is also association with the infantile sialic acid storage disorders, that is paroxysmal and lysosomal storage disorder, like in my case. And this slide shows about the single gene association of binders phenotype. And as of now, only 2 cases were reported of prenatally detected binders phenotype and lysosomal storage disorder association so far in the literature. And my case is one such that, where my case is a 25-year-old lady who is a consanguineous couple of 3rd degree, primary gravida, came to me with in her first pregnancy at 19 weeks in view of binders phases. Her double marker test was low risk for aneuploidies. When I did a TIFA scan, it showed, in additionally to the binder's phase, there was a mild bilateral ventriculomegaly, and there was a classical binder phases, like I could see a flat nasal bridge, short columella, acute nasolabial angle, perialar flatness, and convex upper lip. Frontonasal angle was 154 degree, which was increased, and mild biventricular hypertrophy of the heart, echogenic focus in the heart, short long bones with epiphyseal stippling, calcaneal calcification, but coccyx was normal. And there was no high-risk factors like congenital syphilis, rubella, infection screening, and autoimmune disease, autocoagulation that seemed responsible for the causation of the binders phenotype. Hence, in view of this consanguinity and unique ultrasound features, I have counseled for exome sequencing and did an amniocentesis at 19 weeks, and samples were sent for the testing. But couple opted for MTP and fetal autopsy was declined. The patient was lost for follow-up later, and hence postnatal images could not be collected. The report came back to be positive for GNP tab mutation, which was in homozygous state, and it is a likely pathogenic variant for mucolipidosis 2 and 3, alpha and beta types. And the most of the phenotypic features in the ultrasound, like kind of a skeletal abnormality, short stature, cardiomegaly, was proven to be genotypically associated. There is a phenotype and genotype association were also found in this variant. And patient came to me again for a preconceptional counseling. So hence I advised for a couple carrier screening, but couple opted for a DO whole exome sequencing. So whole exome sequencing of the couple obviously found to be, both the parents were found to be a heterozygous, that is a carrier trait for the same GNP tab mutation, which was likely pathogenic for a mucolipidosis disease. And in additionally, both the couple were carriers for most lot of OOS variants, and also husband alone was found to be a carrier for a pathogenic and likely pathogenic variant. Hence, I had advised that they need fetal testing in all their future pregnancies. So luckily, the patient came back to me in her second pregnancy, which was a spontaneous conception, and I did a CVS at 13 weeks and sent a sample for CMA, which was normal, and whole exome sequencing, where the variant was seen in a heterozygous state, that is a carrier state like that of a father and mother. So TIFA, which was done, was also normal with no obvious fetal defects, and advised to continue the pregnancy, and she is presently at 28 weeks of gestation. The take-home message from this talk is that today we know that binders phenotype is considered to be a heterogeneous phenotype with multifactorial origin rather than a single nosological entity. And all this binder phenotype has a mild form of chondrodysplasia punctata with a stippling of bones. So it is due to its rarity, only few case reports exist which outlines the prenatal diagnosis, management, or the prognosis of the fetus. And most of the pregnancy end up with termination of pregnancy because as more serious syndromes could not be excluded antenatally. And if the patient wants to continue the pregnancy, the normal familial facial features should be considered before concluding that whether the observed features in the fetus is normal or pathological. The invasive testing should be offered, mostly a microarray and a exome sequencing, then a rather karyotype is advised as it identifies common chromosomal abnormalities and microdeletions. Additionally, blood tests for ANA, LFTs, vitamin K deficiency, and drug assay for chronic conditions are also recommended. And counseling by a multidisciplinary team consisting of a fetal medicine specialist, primary obstetrician, neonatologist, and also pediatric surgeons, pediatric orthodontist is pertinent. And serial ultrasound monitoring for a growth, liquor, and any evolving pathology should be done. And delivery should be planned in a tertiary care center, as a neonate may experience an immediate respiratory compromise, and mode of delivery is obviously based on the obstetric indications. Thank you.
Thank you, Navya. That was a beautifully presented case. May I request you in the future to make sure that all semblances of identity of our patients must be removed from the reports to protect their anonymity. The exome sequencing report had the names of the couple, so we should be careful about that in the future.
Yes, sir. Sure, sir.
Questions from our expert panel, please.
I couldn't stop sharing here. Yes.
Excellent. So we have no questions here. We will address, of course, this question on whether all binders need a whole exome sequencing and the audience interaction section. And we move on to our next case.
For our next case, we have Dr. Shadab Nasser, a very interesting case of clefts that he will be presenting. Dr. Shadab, could you screen share, please? Dr. Shadab, are you here?
Shadab is there, and I think she needs to unmute herself. Is she able to Yes. Shadab, you'll be able to now unmute yourself. Yes, and go on to screen share.
Yeah, very good evening, one and all. I'm sharing my case. Just a minute.
Screen share, big arrow that you can see.
Is it visible?
No, we're not able to see your
No, you haven't shared your screen yet, ma'am. Please click on green button share screen, then choose your window with chat to share and share.
Have you opened your PowerPoint as yet, Shadab? Yes, wonderful. Excellent. We do see an advertisement by a cosmetics company, but we
sorry,
yes, not to worry, not to worry. Share the correct screen, my child.
Sir, is it visible?
No, we're still looking at the at a cosmetic company ad.
Okay, sorry. I'm trying.
You shared the wrong screen, yes. If you could
Yeah, how to cancel it? Stop share. Okay.
Yeah, stop share and share the correct one.
Okay.
Yes, now share the correct one.
Okay.
Open your PowerPoint first.
So it is opened in background, but
now go to share screen. The green arrow, the big arrow, the black arrow on the green background.
You can just float the tab you are sharing on the mobile, right?
yeah, sir. Actually, it was not working on tab. That's
So
why
you can just float the tab. Which one is the right tab? You can close all tab and just open the PPT which you want to share. Close the all tab, all other tabs.
So
Yeah.
on share, there are options like document. Shall I go to document?
No,
Microsoft?
not the arrowhead.
Just open the PowerPoint. Close all other windows. Just open the PowerPoint and share screen. Then open the share screen. That PowerPoint one.
Microsoft Share. Sorry, I'm taking time. So after clicking on share, there is no option. It is not showing background PPT.
Dr. Shadab, why don't you send your presentation to somebody? In the meantime, we can ask somebody else to present.
Ma'am, I'm just typing you in chat my number, so you can just WhatsApp me on that. I will share on behalf of.
Okay, thank you, sir.
And perhaps then we can move on to our next case and come back to this. So if Colonel Rima can announce our next
sir.
case. And
So
then
Dr.
we will
Dhaval,
shut up. Yes.
yes, sir. So Dr. Dhaval Patel will be presenting the next case on congenital posterior medial bowing of tibia and fibula. It's an interesting case. Dr. Dhaval, could you please share your screen? So he's hit a hat trick with 3 cases, all being selected by judges. Yes, your screen is being shared.
And full screen. Excellent.
My screen is visible, my arrow is visible.
Yes, and your voice is heard.
Except I am not visible.
That doesn't matter, not to worry.
Yeah. See, this is my third case, and Mrs. X, 32-year-old female, fourth gravida, high BMI patient, BMI is 36, and previous 2 CS, have 13 weeks, 5 days pregnancy, according to her LMP, but by CRL wise is 12 weeks, 5 days, RH positive with non-case of pre-gestational diabetes, no other medical illness. My USG findings is mesomelic shortening of the left leg, short tibia and fibula with the posterior middle bowing of the left leg, dorsiflex foot against the tibia. It's a calcaneovalgus deformity, lower limb length discrepancy, and right foot CTV. Restricted lower limb movement observed from the knee joint. Basically, this pathology is a 2 type of etiology, the primary and the secondary. Primary is abnormal embryologic development such as the limb bud or circulatory abnormalities, and intrauterine fracture has also been suggested in some cases as a possible of development etiology. And secondary is a main cause is secondary is to abnormal fetal position with the dorsiflex foot plastered against the anterior aspect of the tibia. So this is the images. This is the right foot is query CTV, left foot is a calcaneovalgus deformity. The CRL is a high BMI patient. I hardly get the window for this CRL. It's a 12 weeks, 5 days, 65 CRL. And this is the posterior medial bowing of the tibia. See, this is the posterior posterior medial bowing and tibia and fibula on the left side. The right side tibia fibula absolutely normal. Both femur is also normal. See, this is again left side tibia fibula. It's bowing. This is the by transvaginal sonography. This one is a right leg. This one is a left leg. It's a very high BMI patients. So transabdominal didn't get any window. So did transvaginal sonography to get the images and the videos. The lower limb movement is very restricted. Same positions. In spite of tapping and all things, but the movement is not changed. Both femur is normal. And finally, I did this volume. This is the left side. Tubulo-fibula bowing, and there's a calcaneovalgus deformity. And this one is the below one is a right leg. The CTV is Here is a CTV completely seen. Just 12 weeks, 5 days, is high BMI. Below one is the right leg. The frontal one is a left leg with the fibular deformity. See, this is CTV is clearly visible. Calcaneovalgus deformity is also visible. So the treatment is initial treatment of the tibia bovine foot deformities include after delivery, the stretching, serial casting, and the splinting. The bovine deformity is rapidly corrects. 50% correction is usually with the age of the 2 years, though a mild deformity often persists. A tibial osteotomy is a very rarely indicated, will require limb equalizing procedures. When the limb length inequality more than 5 centimeters, in such cases, lengthening procedure may be held. Posterior medial bowing typically self-resolve, leaving only the limb length inequality to be addressed. So prognosis in this such condition, although the angulation and the foot deformity associated with the posterior medial bowing improved dramatically, and some degree of deformity, including tibial torsion and some muscles atrophy, often remains. So this is usually not a significant disability. So according to this congenital tibia fibula bovine, the differential diagnosis is the first close differential diagnosis is the fibular hemimelia, and the congenital deficiency of the fibula has a strongly association with the shortening of the bowing of the tibia and foot deformity. Tibial hemimelia, in these cases, the tibial deficiency or the tibial hemimelia is an uncommon abnormality compared to the fibular hemimelia. And this tubular hemimelia is usually sporadic, although some autosomal dominant inheritance is pattern has been reported in bilateral cases. And another strong BD is a pseudoarthrosis of the tibia. It is a congenital pseudoarthrosis of the tibia, is a rare disease with the interruption of the medullary canal and the bone cortex. So in this pseudoarthrosis, the anteromedial bowing instead of the posteromedial bowing of the tibia and fibula is present at birth, with the fracture in the first decade of the life and subsequently development pseudoarthrosis, limb shortening, and the variable lower limb deficiency. And the others are differential diagnosis is the tibia vera, Blount's disease, and Ehlers disease. So ultimately, this patient after counseling, but they are terminate this pregnancy at 13 weeks. No DNA store, no genetic testing was done. So according to this syndromic condition, there are the few keys for the differential diagnosis are there fractures? Is ossification is normal? Is angulation mid-shaft or at joint? Is distal limbs is normal? One limb or versus more than one limb is affected? Are both segments of limb affected? Are abnormalities limited to the long bones, or any other skeletal elements or any other system is affected? Are any segments missing or hypoplastic? Are there any other non-skeletal structural anomalies is there? Thank you, sir.
Thank you very much, Dhaval. And the forum is now open to our expert panelists. If there are no comments, we move on to our next case. And
I have received Shadab presentation, so we can.
That's very nice. So we give her the chance now, and Shadab, if we will keep listening to you while the admin switches on your presentation.
Okay, sir. Very good evening one and all. I am Dr. Shada from Aurangabad, Maharashtra. Okay, sir, slide, sir. Okay, slide. First of all, thanks for giving me opportunity. Now I'm presenting the case. 25-year-old G4P2L2A1 female came for anomaly scan at my center. She was having primary hypothyroidism since many years, and she was taking medicine intermittently. Next slide, sir. So I am only telling the positive findings on USG I found. There was a large cleft seen involving the bilateral nostril, wings, maxilla, and the medial orbits. Lips were normal, absolutely normal, and no other anomaly detected. So you can appreciate the cleft very grossly. I can appreciate at the time. Next slide. On coronal view, there was a that is echogenic ridge-like structure. It was, I thought it is a columella. And the next slide. So there was gross facial dysmorphism I could appreciate. There was absent alinesi, and this you can appreciate on video how this cleft was continuing to the medial orbits. Sir, please video. So you can see the gross cleft. Yes, sir. In video, you can appreciate the gross cleft continuing from the columella to the infraorbital ridge. So honestly speaking, I could not give the term to this cleft at that time. I just explained the large cleft in my reports. But it was so unusual. I was behind this case, and on follow-up, I got the image after birth of this image after this video. Yeah, this is the afterbirth picture of the baby. She is a female child, and I took the history. She is having no feeding difficulties, and I was so much surprised, and I was wonder what is this. I have never seen this kind of cleft, this kind of large cleft. And retrospectively, then I saw my videos and images. You can also see, then you will appreciate more. Sir, please, next slide. This cleft is continuing from the columella, from nasal alli to the infraorbital ridge. So there is what is coloboma of lower eyelids and the absent alinesi. So finally, for my final diagnosis, I came to my final diagnosis on respectively, that was a severe bilateral Tesier 3 cleft. Yes, next slide. It is also called as oral nasal ocular cleft. It is very rare type of lateral facial cleft. And this malformation is a paranasal medial orbitomaxillary cleft running across the lacrimal segment of the lower eyelid and over the lacrimal groove. It typically extends from the philtrum of the upper lip through the wing of the nostril and reaches the medial canthus of the eye. And it can be associated with other craniofacial anomalies. Next slide, sir. Tesier classified the facial clefts and from 0 to 14. Roughly 0 to 7 are below the orbit. These are facial clefts, and 8 to 14 are above the orbit. These are called as faciocranial clefts. Okay. Next slide. So this cleft is due to non-fusion of the frontonasal prominence in nasal placard and the maxillary process, which this fusion occurs at the 4th to 5th week of embryonic life. So it occurs due to non-fusion of this time of these structures, or due to disruption after fusion occurs. Next slide, sir. TZR number 3 cleft is among the most challenging malformation for reconstructive surgeons to correct. Treatment presents significant difficulties. Patient with TZR number 3 cleft can achieve favorable outcomes when treated by a skilled surgical team. Thank you very much, sir. Hello.
Thank you, Shadab. Any inputs from our expert panel, or should we keep questions for the end? We have, because of the problem with the changeover of a thing, we ran short of time for Dr. Shadab. But I guess we'll take questions at the end for any questions from her. So if we can move on to our next case, please.
So our next case is Dr. Sri Lakshmi KN. She'll be presenting a case of cri du chat syndrome and partial trisomy 7q. Dr. Sri Lakshmi KN.
Hello, good evening. Good evening, all of you.
Good evening.
Yeah.
The screen share,
Yeah.
please.
Yes, sir.
Are you having difficulty with your screen share?
Yes, sir.
Can we
I
help
do
you?
have the difficulty. Mm,
If you use the black arrow in the green square and you click on that, you will get the screens that you have for sharing. And admin, could you please assist further?
I'm just click on the share screen button at
share screen
green in
button.
bottom.
Yes, I
Yeah.
do that. And from there, I'm not getting anything.
Then you can see multiple tabs which you have open in your laptop.
Okay.
Then
Wait.
just see which one you want to share, which have opened your slides. So you can just click on that and share.
Mm.
Is it presentation on, ma'am?
She is disconnected, I think.
Okay, so can we move on to the next
Yes,
and then
please.
come
Dr.
back to her
Shubhangi?
later? Yeah.
Yes, sir. So Dr. Shubhangi will be presenting a rare gene mutation. Dr. Shubhangi,
Yes, ma'am.
please share your screen.
Dr. Subhangi, please leave from one device. You are actually going too much.
You have to log in from one device only, Dr. Shubhangi.
Yeah, she has logged in with two. Now please share your screen.
And if you could go to full screen, please.
Yeah. Is the screen visible, sir?
Yes,
Yeah. Just go to full screen. Yes. Now you're there.
Now I'm there. All right.
Yeah.
Okay.
Hello, good evening all. Thank you for giving this opportunity. Actually, I take this as a learning opportunity for myself, as this case is not personally mine. This is one of my friends who is doctor and she is the patient of this case. So I would like to present this case because I want to learn few things from this. And yes, I mean, there are experts in the panel and I would love their feedbacks. So she was 32 years old, a healthy female, had non-consanguineous marriage. She conceived spontaneously after 2 years of marriage. The pregnancy was completely uneventful with no gestational comorbidities. This is a very simple case. Like after listening to all these beautiful cases, I think this is not that great, but then still I would like to present it. So that uneventful pregnancy, at 39 weeks, 2 days, patient was admitted for induction of labor. She was taken for emergency LSS in view of fetal distress. The index case, the newborn who was born, newborn presented with delayed cry at birth. There was hypotonia and lethargy since birth. He developed multifocal seizures at 1 month of age. The baby was investigated. His MRI showed features of mild hypoxic ischemic encephalopathy. Earlier, it was thought that this is insult during delivery. But then later his basic metabolic workup was done, which came out to be normal. And echocardiography showed impaired left ventricular function. He was suspected to be affected with encephalopathy or inborn errors of metabolism and was found to harbor variations in GABRB3 and ADSL genes. This index case genetic workup, the ADSL gene was found on exon 1 and 5. It was autosomal recessive and there was no significance. It was a variant of uncertain insignificance, variant of uncertain significance. The parents were also tested. Unfortunately, I don't have GABRB report of the index case. The parental genetic reports, mother had GABRB gene mutation on exon 8. Father did not have one. Then both the parents were tested for ADSL gene mutation. Both had, mother had it on exon 1, it was heterozygous, and father had it on the exon 5. But both parents were asymptomatic. There is no family history of any convulsions. So entire pedigree was tested and there was no family history relating to this index case. So these results indicate that the parents are asymptomatic heterozygous carriers of one of each variations detected in the index patient, and hence these are compound heterozygous variations detected in index patient. Most variants in GABRB are reported to be de novo. So even if the parents were not the carriers, it could have happened to come in the newborn, but one of the parents was harboring the gene mutation. So the outcome was baby was on treatment for intermittent convulsions. Baby achieved milestones very good in early age, but later it stopped progressing. And at the age of 10 months, baby passed away with the final episode of tonic convulsions. The same patient, she planned another pregnancy after 2 years. It was a spontaneous conception. Antenatal care was followed up very well because of the previous loss. The aneuploidy screening was normal. Geneticist consultation was done to discuss about amniocentesis if it is needed. Unfortunately, she was in some other state for her further education. She was native from Maharashtra and like she could not get somebody whom she knows, but she was in care. She was under care with fetal medicine specialist only. And she was in contact with me. She used to send me the reports and then we somehow could manage to talk with the geneticist and they advised that this amniocentesis in this case is not required as the previous genetic mutations which were found were of uncertain significance. So it need not come in the present pregnancy. Then at 18 weeks, target scan was done. There was microcephaly, which was documented. She had just sent me the reports. I mean, nobody documented it as microcephaly on the scan there where she had done it. I just went through the centiles of the measurements, and I found it that this head circumference is little on the lesser side. Then she again went to another sonologist, and then they somehow corrected the dates and said that it is normal. So I think this point was missed somewhere, and it was not carried forward as macrocephaly, and it was neglected. So this wasn't reported as microcephaly in the report somehow. And she had gone to another fetal medicine specialist where the dates were corrected. Now, in the second pregnancy also, she did not have any gestational comorbidities. It was uneventful. There was a planned LSCS at 39 weeks. But this time also it was a very unexpected outcome. Baby landed up in NICU immediately after delivery. Baby was ventilated. Baby had convulsions in NICU. This baby also passed away at day 10 postpartum. This baby was also found to have similar ADSL gene variation, which was heterozygous, pathologically insignificant. So I think more vigilance and detailed family history and invasive testing should have been done, or like how should the case have been managed, like to have a favorable outcome, or I mean, like could it be terminated at the earlier gestation to prevent the mental trauma? How to manage these cases? I mean, like I have questions.
I guess we have Dr. Bhavna to give us some inputs on this.
Yes, sir. Sure, sir. So, very nice case, and we do have these views in the exomes, which are nightmares even for a geneticist. So, here, doctor, just wanted to highlight that in the presence of microcephaly, in the presence of ADSL, actually all the prenatal setting, we follow the ACMG guidelines for testing and recommending invasive on the basis of prenatal results. So, ACMG clearly says that pathogenic and likely pathogenic. A question is also there in the chat box regarding the same question. They need to be, targeted in the prenatal testing. But if you're finding a VUS, deep phenotyping is required. Like in your case, there was microcephaly, there was a Crow's phenotype match with the ADSL gene, and also the reclassification every time you are looking at the report, because the variants keep on changing. To me, if I see one of the variant is likely pathogenic at present state, and other is VUS. So the databases keep on updating. You have to reclassify the variants every time you are, at least 6 monthly or yearly, when you're visiting a patient with a report of previous child affected with a genetic disorder or the same child. So here the dilemma could have been resolved because it's a LP and VUS with a phenotype match. A proper documentation discussing this with the patient, fetal medicine, geneticist, and gynecologist in loop should be done, and then the decision could have been taken. So deep phenotyping is the answer, proper counseling is the answer. It's not that VUS is a strict no-no, but yes, there is a paragraph in the ACMG guideline also which says that if you are targeting these variants, a proper documentation, one-to-one counseling, and a proper deep phenotyping is required. So I think that is a dilemma, a gray zone, but it can be catered in a manner like we have discussed. If there are suggestions from Dr. Sani and Dr. Khurana, I may be like, there is a difference in opinion.
I wanted to add one point.
Yes, yes.
That this being the second case, and having doubts on the VUS, one thing that could have been done maybe at a postmortem or probably postnatal time is taking the skin fibroblasts and testing for ADSL immunostaining. Most of the times ADSL immunostaining would come as negative, and that would be an additional way rather than just depending only on the VUS.
Definitely. All the opportunities to have functional analysis, like sir is mentioning, should be done to reclassify the variant, because that would add pathogenicity thing to this variant.
Could you elaborate on that, Bhavna? What are these functional?
Like sir is mentioning, sir, like we are showing that because of the staining, the staining is showing that there is a defect in the protein. Or we can do RNA sequencing. If we are actually targeting the downstream effects in the RNA and the protein, or for that matter, animal models, though they are still in infancy in India, but people are working strongly in those lines also. And also very simple biochemical screening is, functional screening is in cases of LSD. If we have a VUS in say Tay-Sachs disease, you can easily perform an enzyme analysis for that. That is easily available. So all those things are there, sir, and that can be done.
Excellent. And while we're on this case, I think we can answer that question that's been in the chat box since the beginning. Dr. Aparna, thank you so much. Thank you so much for this presentation. I think we'll continue the discussion here. And if Dr. Aparna can take over and discuss this bit a little further. There was this question in the chat box right in the beginning on what we do with the woos and what's the best way to handle them.
Yeah, so good evening, everyone. I think we do have, sir, should we take these questions here only, right?
I think so, because it's very relevant at this point. Yes.
Right. So I think there have been, although a lot of questions have been answered, but there were a few questions like what to do. So I'll just go back on that. Sorry about that. Yeah. See this. There was one question on whether do all binders need VES? I think that is one thing, and there was one thing on the do all the
I could see one
VOUS.
question. Yes, ma'am. One question was on VUS, what to do, whether prenatal decision should be done on that basis. So that is partly answered, I think, by this. Other question was if we have a lot of LOH in CMA.
Yes, what is the
significance?
significance of LOH in CMA done for soft markers for aneuploidy?
Yes. So
If otherwise CMA.
yes. So very good question. LOH is actually loss of heterozygosity. So in a lot of consanguineous couple, they are, easily finding which is benign and easily, seen. But when you have a LOH, specifically when you have LOH in chromosomes which have predisposition for UPD, uniparental disomy, like chromosome 15, chromosome 7, chromosome 11, they can actually point towards UPD in the fetus, or UPD testing would be required. And also when you have a LOH, there can be unmasking of autosomal recessive disorders. So those two things have to be kept in mind. When we have a long stretch of LOH in the CMA, we are thinking CMA is negative of some genetic disorder. We can actually see for autosomal recessive genes in those areas, and actually can find some mutation in those areas. So these two things are there, ma'am, which are important. And there are guidelines for these stretches of LOH, how much if they are there in what particular chromosome, regions like telomeric region or centromeric region. We have to take discussions with the patient on that basis. So I think that is important.
Right. So thank you for that. And I think the other question was that can we take clinical decisions based on VOUS? And I think you've explained that a lot, that we have to kind of work back and
Yes,
see
ma'am.
if there is any phenotypic association with the VOS that has been described. And it's always like, a continuous updation of what is already described and what we are learning. And if there is, then we go back on the thing and we say, okay, now we have learned something new and there may be association in the future. So I think this is something which is already evolving. So I think this is all for now. Sir, can we do the last case?
Yeah. Dr. Rao wants to say something. Yeah.
Yes.
I wanted to add 2 points. One is dependence on whole exome sequencing. There is one needs to also need to look at it whether it is a clinical exome or whole exome. We would kind of miss out quite a bit of thing, especially those that are not covered by the regular clinical exome. So and medgenome, because of the business model, most of it I'm seeing a lot of the things are coming from medgenome. Because of the business model, they have various stratification of the their models or products. So that is one thing. And second part is Government of India, CSIR, IGIB also has Guardian network. So if there are any genes that the clinician thinks that there could be some genetic abnormality and that are not yet detected, you can actually just go to Guardian network and send your samples for free, and they would be able to test it for you. So please make use of it also.
Yes, in fact, this is a very important point that you brought out, that originally, because traditionally in India, we keep saying, bring the price down, bring the price down. The so-called whole exome was reduced to a clinical exome. And it was more of a marketing gimmick, as we have realized, and has caused more harm than good. And we do understand that there is such a thing as exome sequencing. And if we give the right phenotype or the right information from that family and from that case, then the geneticist who's working in the lab will specifically look for exactly that when they are doing their sequencing, and make sure that when they get that data, they will specifically look for it. So the database has to be fine-tuned at a very personalized level for that particular case. So in today's day and age, we should not talk about a clinical exome because it doesn't fit. There is just too much of deep phenotyping and additional clinical information that we need to use. We also realize that exome sequencing is no longer a single test, and that you can have a much deeper sequencing done by some people, which is called the high pass sequencing and so on. And we need to depend on that. We also need to keep in mind that if we just add a few genes here and there, and we emphasize this in a personal conversation with the lab, then we will get better results. So that kind of a dialogue is now absolutely imperative that we have for our patients. And of course, there is this cost consideration, which is an artificial situation, because it's no additional cost except for the amount of work to be put in by the lab. But we know that the only way forward in genetics today, even for the labs to be used optimally by themselves, is to make sure that they put in that extra bit of intellectual work. Otherwise, the commerce is not going to work. So they have to draw a balance there. And it is for you and me to demand that balance. And that's what we should be doing. And there was also this one question which Bhavna can answer while we are on this question. And that is, when do we make an unknown significance into a significant variant? And what are
Yes.
the rules for that?
So the question was put up like this: ki how many times it should be reported to call it as a pathogenic? So probably the answer is even if it is reported 100 times, it's not going to be pathogenic. The pathogenicity of the variant depends on 28 ACMG criteria, as Dr. Rao also said, that if we have functional analysis performed, if we have segregation of that variant in multiple phenotypically matching patient, it need to be reported in phenotypically matching patients. Segregation in multiple matching patients, functional analysis of the variant, not just the in silico predictions, actual functional analysis, like Dr. Rao was mentioning, in tissues by immunoblotting or downstream effects. So that is important to reclassify the variant. So even if I'm reporting it as a WUS in a patient where the phenotype is not matching, other person is also reporting, it's not going to be turned into LP or P. So the criteria is very strict, and the classification has to be right for counseling also. So I think that answers that question, sir.
Yes, we would never look at the number of reports. We would really go, because if one single case example can clinch a change over, then that is enough for us to change.
Yes, sir. Even if one single case has done the entire work of functional analysis, it will be reported as in the future pathogenic.
Yes, yes.
And Dr. Kurana, I want to add one point here. I am seeing that a lot of there is a good amount of penetration in terms of getting genetic testing. When it comes to adult clinicians, it's very difficult. Whenever we talk to them, they say, what is the point of getting the testing? There is no treatment. What's the point? Why are you wasting 12,000 of my? But here I'm seeing left and right, there are a lot of genetic testing available. Parental segregation data is also available. It is very heartening to see this data. So I think that is great thing. But this data needs to be kept somewhere, maybe with your society. This needs to be documented and kept with all these boosts, so that it can be used for research purposes. And secondly, these kind of very interesting cases, if the samples are also collected and kept in a biobank or some sort. Biobank Foundation is there in Delhi that is starting a very great work, and they are also collaborating with multiple places. That is something, if your society can take up then it will be very helpful for a lot of patients and researchers.
Yes, we've already started work in that direction, and of course, highly motivated people from genetics like Bhavna will work together in the very near future with Shagun Agarwal as well as with Dr. Ratnapuri and the SIAMG to put together this in a more accessible format, because it has to be a two-way process. And we do hope that we will fast track it just like we fast tracked everything else. One of the best methods really for convincing our patients that this is a good investment is not to tell them that this is a small amount of money, but we've all learned from each other and we know that it is that, look, this might affect your next pregnancy and please don't come back to me with the same sad story. And therefore we have that little bit of an advantage. And of course, we have a very close-knit organization. But thank you indeed for that compliment. We will keep working towards making it better and better. And do we have, are we ready for that last presentation?
Yeah. Dr.
So that's Dr. Sri Lakshmi, KN, who will be presenting on cri du chat syndrome and partial trisomy 7q. Dr. Sri Lakshmi, KN.
Were we able to connect her presentation?
Has the admin received the case?
No, ma'am, but she's here. If you can send.
If you can unmute her, yeah.
Yeah.
Yeah. Can you try sharing? Yeah. It's
Yes,
coming.
thanks.
It's coming. Yes, good.
Excellent.
Okay. Are you able to see my screen, sir?
Yes, if you can go to full screen.
Yeah, I am trying to put it in a slideshow.
Yes.
The story started, yeah, sir. My background is I do fetal medicine and I have a fellowship on medical genetics. So I do get cases for ultrasound and sometimes I do get directly for genetic counseling and fetal autopsy. So the story started for this patient like this. They had the family was a third degree consanguineous marriage. It is consanguineous marriages are very common in our area, and she had one live healthy child, a girl child, and because of the gender bias, they do keep trying to have the male baby. Because of that, they had 4 non-recurrent multiple anomalies, but father was very sure that all of them had a cardiac anomaly, but they didn't have the ultrasound reports. Present one was a 6th pregnancy, and it was a 22 weeks anomaly scan, which showed single umbilical artery, pericardial effusion, query double outlet right ventricle, and they could not image the ductus venosus, and they had commented that there was a direct entry of ductus venosus to umbilical vein. And but since it were two things were pointing into my case were consanguineous marriage and a recurrent anomaly, that too it was a cardiac anomaly. So I pursued the importance of fetal autopsy and the genetic condition. So I asked for fetal autopsy. When I saw the fetus, these were the findings. There was depressed nasal bridge, long philtrum, low set ears, and overlapping toes. And it was a common arterial trunk, and single umbilical artery was definitely present. So when I could correlate, although consanguineous marriage and recurrent anomaly were pointing to me asking for a whole exome sequencing, I was not convinced that these findings are single gene disorder, because there were a lot of dysmorphic facial features and common arterial trunk. So I was these findings were more in favor of deletion and duplication syndrome rather than a single gene disorder. So I counseled the father and told him the importance of sequential genetic testing. So I asked, I stored DNA for all the fetuses. So I asked for a chromosomal microarray, and if that doesn't yield the report, then we'll go for a whole exome. But chromosomal microarray showed a deletion on chromosome 5 and duplication on chromosome 9, suggestive of cri du chat syndrome and partial trisomy 7q, suggestive of microcephaly, round face hypertelorism, micrognathia, epicanthic folds, hypotonia, intellectual disability. Duplication are suggestive of developmental delay and dysmorphism. So I counseled them for a couple karyotype, and in the evening, to complete the case, I called him up and asked, did you get the report of couple karyotype? Because I was on a follow-up for them. He has got a tubectomy done for his wife, and he said, I am happy and peaceful now. So 2 lessons I learned when I worked up this case are, it is very important to correlate all the findings and ask for the relevant genetic testing. If I had asked for an exome sequencing, I would have definitely missed the answer for this patient, because dysmorphic features are definitely indicating the deletion and duplication syndromes. And however good we have the rapport with the patient answers and patient import are quite different. We asked for a couple karyotype, financial constraints were not there, and the lab was even ready to get it done free, but he just absconded from my OPD and has got an OPD tubectomy done. So yes, this is chromosomal microarray has a lot of role in workup of the cases. And see the fetus. The fetus wants to help the parents even after the termination. We just have to see the fetus. If I had not seen the fetus and gone with only with the ultrasound findings, again I would have missed the case. Thank you very much for the opportunity, and really appreciate all of you seniors to be with at this point of time to listen to my case. Yeah, thank you.
Thank you so much. You know, we are one family, and that's there's no denying that. So that's the end of the presentations, and I guess Bimal for a few words and then our closing remarks.
Any comments, anything, sir?
God bless you.
Any comments, Bhavna?
This
Anything
case,
on-
yes, sir. So this case, you need not to have the dysmorphic features in the autopsy. It's very good that you completed the workup, but the pedigree itself is saying that it is chromosomal, and one of the parents is going to be balanced translocation carrier. So this family was actually unfortunate that 5th pregnancy, the workup was started and it was done eventually. Even after first or second, when the 2 fetuses had heart defect, think
they should have gone.
this should have thought of rather than retrospectively doing it. And another thing is this balanced translocation carrier, almost all of the pregnancies, they'll have either abnormal fetus or abortion. So prenatal testing should be offered. So that is the lesson. And it will be not picked up in CMA because it's balanced. So karyotype,
yes.
so age-old testing, it has still
It is
the role
it
in
has
the
a
clinical practice.
definitely.
Yes. Thank you for the special case.
Share your screen, and Aparna has.
Yes, no, so not on this case, but I would just like to say that, as a general comment, I think wonderful cases. I went through all of them, all of the cases, and, it was a great learning for us as well. I would just like to say, we see these patients, so many patients every day. We go through these genetic testings and, we have our colleagues, we keep discussing. But out of the 100 cases that we see, these are the cases are like the tip of the icebergs that we present, that you do have a positive finding and then you are able to, provide some answers. But rest of the 99 cases, we don't get, there is a possibility that, we do not get too many answers. So what is the crux of the matter is also that we provide a good pre-test counseling. That is extremely, extremely important. Because at the end of the day, you have a test which is showing something which is not the answer for a question that you are asking. And the patient is sitting with a report and she says, okay, this is not the answer, but this is a different question for which I want an answer. So please terminate this pregnancy. So it is extremely important that we go into this myriad of genetic testing with a very good pre-test counseling. Because, very recently I had a patient who was 8th gravida with bad obstetric history, with multiple babies having SCID, severe combined immunodeficiency. Fortunately, this baby did not have SCID, but this baby's vest showed booze, for which she terminated this pregnancy, despite our counseling. So we have to understand that this genetic testing is a double-edged sword. While it provides wonderful answers to the questions which we thought would never be answered, but then it raises questions to the things that we never thought would be questioned. So let us understand that our geneticists are our most valued resources. So before we go for testing, let us consult and also tell them that, okay, here we are going for some test. It is not like 100% answer. So please, that is what I want to say, that this is not something that's going to give 100%, and let us not base our clinical decisions completely on these tests. So that is something that I wanted to add.
Aparna, what an important, I think you kept the most important message for the last. The pre-test counseling is the most important thing, because see, whenever we attend these kind of webinars on rare diseases and all, then a lot of times everybody feels that, okay, this is a webinar on genetics, I don't need to attend that. This is all about genetics. This is all about genetics. But that's the way life is now. Fetal medicine is definitely, genetics is the major part of fetal medicine. And hence, it's important for anybody who's into, I think, in any way associated with the fetus, it is important that they get awareness about what options are available, what genetic test. We've seen through some of the cases today that, yes, even what test needs to be done also is a very important entity. And that is something which because geneticists are not only a very important resource, but they are also in scarcity. Very limited availability of geneticists in our country at the moment. So not everybody has an access to that, and hence it is becoming very important that everyone who is practicing anything in fetal medicine at any place, I know, yes, you don't need to really, you won't be able to get into the depth of genetics, but a working knowledge about genetics is very important, because right at your level, you are guiding them to the right test in the right place. As far as rare things are concerned, again, we leave with the notion, okay, this is very rare. When am I going to see it? But when you go through this, you never know. Monday morning, you may find something, a findings very similar. And that time, what you're going to remember is you're going to remember this webinar. Oh my God, yeah, there's somebody who showed us this. And I think, the efforts taken by the first person, the second one who has heard it is going to benefit out of it. And right from the beginning, go on the right track. And yes, again, because whenever there is too much of discussion on genetics, I always like to end up with my favorite statement that there's no genotype without a phenotype. And hence, it's very, very important that I think the geneticists can give us the best results as long as we give them the best phenotype. We need to, small findings, anything you may find which is not looking normal, you may not be able to define what that abnormality is, but if you can just mention that also in the report, that is going to help the geneticist in, all these we talk about, whether this is pathogenic, not pathogenic, but everything is related to the phenotype. So thank you. Wonderful cases, wonderful meeting, and SFM. I think this trend of having webinars on all these international days is really, really helping everyone, all our members, non-members who are attending these meetings. And this is a great way of going ahead. And Dr. Rao, your inputs, listening to you today, actually, this is the first time I really knew there is so much that is being done. And there are so many avenues that we can contribute. If we want to really give back something to the society, there is so much that we can do. And the government is there with us. We always say, government kuch nahi karega, but there is so much that is happening. And thank you for bringing all those things to us. This is, we will take a lot of your messages forward in any form we can, because we are a very close-knit society. We work like a family, and hence getting things going in our society is much faster than it happens at other places, because we are a very cohesive group, and we will take up a lot of your suggestions, and we will really go forward and help, whatever the registries and everything that you have talked about. Thank you very much for that also. And Rima, madam, thank you. for
Thank you
putting
so much. Sir, we would just a vote of thanks to Dr. Sudhendra. He was here with us till the end. It's 11:30 p.m. We thank all the lovely cases were presented by the presenters. There were 20 judges. The judges were fantastic in choosing the first 11. And I thank the experts who have, of course, put in wonderful comments. And Dr. Ashok Khurana, who's been our leader, our guide, and our mentor in taking this forward. Thank you. And the trade partners, of course, we thank all of you. And most importantly, the participants who are still here at 11:30. Thank you so much. We thank each one of you for being with us today. And we are with the cases who suffer from rare disease. We show solidarity today as far as Society of Fetal Medicine is concerned. Thank you so much.
Thank you indeed. Good night.
Right.
Thank you. Good night.
Good night.